To welcome everyone to the meeting number 26 of the House of Commons Standing Committee on Health, pursuant to the order of reference of May 26, 2022. May 26, 2020. Let's not get ahead of ourselves. The committee is resuming its briefing on the Canadian response to the COVID-19 pandemic. To ensure an orderly meeting, I would like to outline a few rules to follow. Interpretation in this video conference will work very much like in a regular committee meeting. You have the choice at the bottom of your screen of either floor, English, or French. As you are speaking, if you plan to alternate from one language to another, you will need to also switch the interpretation channel so it aligns with the language you are speaking. You may want also to allow for a short pause when switching languages. Before speaking, please wait until I recognize you by name or during questions by the member asking the question. When you are ready to speak, you can click on the microphone icon to activate your mic. A reminder that all comments by members and witnesses should be addressed through the chair. When you are not speaking, your mic should be on mute. And I would like now to welcome our first panel of witnesses. As an individual, we have Dr. Joanne Liu, physician and former international president of Doctors Without Borders. With the Canadian Association of Radiologists, we have Dr. Michael Berry, president. We have Dr. Gilles Soulet, vice president. And from South Lake Regional Health Center, we have Arden Crystal, president and chief executive officer. So we will start now with the statements from our witnesses. So we'll start with Dr. Liu. Please go ahead, 10 minutes, please.
Thank you very much, Mr. Chair. Good afternoon, standing committee members. So my intervention will be limited to my area of expertise, which is basically tackling regional epidemic pandemic response at micro and macro level as a humanitarian aid worker, and then through my as well training as a master in education in health and management. So we are nearly going to hit the 100 days of the pandemic landmark, and then very sadly in Quebec, we have reached 5,000 deaths of patients with COVID-19. So I just want to just remind ourselves that we still don't have a vaccine for COVID-19. We still don't have a specific treatment, and we still don't know much about the immunity that we have once we have the infection. So therefore, our best friends and best way of tackling it is mitigating measure for the response. And so my speech would be about preventing the preventable. And so I think that we have a duty to absolutely learn the lessons to be learned after those 100 days. And so I think that we have to understand as well that there's a cost for a response, but despite the cost, because of the pattern of recurrences of a pandemic over the last 15 years, from SARS in 2003, swine flu 2009, MERS 2012, Ebola 2014, 2015, Zika 2015, and then now COVID, is whatever we're going to be doing right now is a rehearsal for next time around, and it's an investment. So we've learned a lot, and we manage as well, throughout that pandemic to manage a shortage of inventory. And so some variables, have been impacted and impacting. And I think I would not go with that because my first statement, a few months ago was highlighting that. But the procurements, the patient and beneficiaries, the personnel, the hospital were like some of them. But the lesson that we learned over the last few months is about the brutality of the disease and the loneliness of patient dying alone. We've learned about the vulnerable different community like the elders, but as well people in prison, homeless people. Hard way how to operationalize IPC, so infection prevention control, in a meaningful way. We learn as well, hopefully, that we have to protect mentally and physically, all our staff and our first line worker. We learned that we should manage mobility of people. We learned that outbreaks happen in hospital, even university hospital, more than what we want. We learned that communication needs coherent message, otherwise people get confused. We learned that the public health needs the basic to be implemented: tests, contact tracing, isolation, and treatment. We learned that in terms of surge capacity, we're stretched, and we learned that access to care has been an issue for non-COVID patients. So what is the role at the governmental level, at the federal level? Now that we have finally, I think, passed the peak and then flattened the curve to a certain extent, we have a breathing space, and then we can probably switch from a mode of being reactive to something that is much more anticipatory. And then what I'm looking for and what I'm begging for is knowing that at the federal is the only place where we have the overview of the whole country. It's some sort of norms and guidance for the best practices to be implemented. And so I have 5 points I'm going to share with you. The first point is second peak versus rebounds. And so I think there's a lot of people who talks with assertiveness about the possibility of a second peak. But the reality, we don't know what is the seasonal behavior, if there's going to be a dormant phase for the coronavirus. So we don't know if it's going to come strong in fall. But we need to prepare ourselves for the worst case scenario. I think that keeping that in mind, I think we should develop a specific strategy in terms of vaccination for influenza, because we don't want to overload our hospital in fall time, knowing that influenza is going to be back. We need to do everything to dampen preempt the second wave if ever it happens. But meanwhile, my biggest fear is repeated rebounds, repeated micro outbreaks away from the epicenter. That's what we've seen in many other outbreaks, with Ebola, with cholera, and then with yellow fever. I know it's different, but nevertheless, I think there is repeat of pattern. So while we are easing down the lockdown, and then we increase mobility of Canadian, especially during the summer vacation, we might be facing micro outbreaks in different places in rural area. Why is it a concern? It is a concern because in many places in rural area, they haven't been exposed and didn't have much case, meaning they don't have much immunity. One thing. The other thing, in hospital in rural areas are often staffed by dépanneur doctor. And then it goes from 20 to 80% of the ER shift are basically covered by locums doctor. So how do we frame the visit of those doctors? We probably won't quarantine them for 14 days. How are we going to make sure that then they don't become vector of the COVID-19? Are we going to test them before they go, test them while they're there? So that's one thing. The other thing about rural area, I would strongly advise to have the implementation of rapid response teams or SWAT teams, like I like to say, to go and stabilize when there's a micro outbreak, and then making sure that we optimize the IPC, and then we support the response. My other concern is about interprovincial mobility and what it can bring in terms of having micro outbreaks. And I think the Campbellton case in New Brunswick is a good example. Someone who moves from an epicenter to a province, to places where there was low transmission, and there we go, we have an outbreak. So I think that at federal, there must be guidance about how we're going to control the interprovincial mobility. At international level, my biggest concern is about, yes, the border. I think we have agreement to be closed until June 21st, if I'm not mistaken. And how are we going to follow through, knowing that it's at federal level that we control the border, but actually the follow through of people probably is going to be at provincial level to the public health. Are we going to follow up the visitor? Are we going to hand over the information on the visitors? Are we going to ask them to self-monitor themselves? Are we going to trace them? Are we going to request them to isolate? So that was my first point on the second wave or micro outbreaks. That was my first point. My second point is about personal burnout. What I've seen in many other outbreaks is when we've passed the first wave, we are facing burnout of personnel, frontline worker. And are we ready to fill up the gap when this will happen? And what is the buffer in terms of staff? And then are we going to have a surge capacity, knowing that as well is going to be pull out of military in some of the places where they've been deployed? And I think that on the midterm, long term, we need to start to think about a civilian reservist workforce that will be trained and can jump in and be functional. For example, the Red Cross has developed some of those models, but we need to think about that, and it should be probably at the federal level. Third point, we need absolute guidance on best practices for testing, contact tracing, and long-term care facilities. And then the reason for testing is because we have people who have mobility, and we know there is some people who are asymptomatic or people who are pre-symptomatic, meaning they don't have symptoms, but they will develop the disease in 1 day to 7 days. And then these people can be vector of the disease. We need to have an overarching strategy about testing, either through swab, serology, and we need to make the system happen. And guidance on that would be quite welcome. I think on the contact tracing, we need to find out, are we going to have the ability and the capacity if we have a second wave? And we know in some provinces it's been a real challenge. What is our research capacity in that respect? And then lastly, in terms of guidance, I think we need to be clear on long-term care facilities in terms of making sure that we test the people in long-term care facilities, we protect them and we staff them properly. But as well, we need to learn from some of the experience that have been successful. The fourth point is about access to care for non-COVID patients. And I think that in many places, we still have a healthcare system that is running at low regime. We need to come with a priority list for sector to scale up, because non-COVID-19 patient cannot be the collateral damage of the response to COVID-19. And I think that guidance would be helpful. And my last point is about at international level. And then we've realized how much we are in a complex way interconnected, interdependent across the world. And then we know that to make all of us safer depends on making each of us safer. Or I can say it another way, to make all of us healthier depends on making each of us healthier. So we cannot tackle COVID-19 in isolation of the rest of the world. Canada has been investing on R&D for vaccine, massive investment locally in Canada, 150 million on R&D of vaccine, although we're not sure about what would be the scale up capacity for manufacturing it if it's successful, and we don't know how affordable, accessible it would be. But more recently, there's been a pledge for more than 600 million for Gavi and the global polio response. And I think that it's important that if we are to plan to invest that much on R&D for vaccine, we absolutely need to get a seat at the table to influence the outcome about the public good as vaccine, on R&D on vaccine, because Canada needs to influence how we will distribute whatever discovery that will happen. And if we don't have a seat at the table proudly, it's going to be really hard to influence the process. Meanwhile, I really urge, that we have as well, we develop a strategy how we will vaccinate the Canadian if we were to have a vaccine available by the end of 2020 or early 2021. We should do that now when we have a bit of a lull time, because we need to find out who we're going to get, we're going to vaccinate in priority, frontlines worker, vulnerable subset population, but we should not improvise that at the last minute. We need to think through that. So to summarize, I think that it is really, really important that we do everything to do the mitigating measure. We still don't have a treatment. We still don't have a vaccine. We don't know about the immunity. We have to prevent the preventable. It's about preventing people to get infected, preventing people to get sick, but it's about lives. Thank you very much.
Thank you, Doctor. We go now to the Canadian Association of Radiologists. Dr. Berry or Dr. Soulé, please go ahead. 10 minutes, please.
Thank you, Mr. Chairman. Can you hear me?
Yes, I can. Please go ahead.
Good. Thanks to the committee and the chairman for having us today. Gilles and I will be sharing the presentation. Just a little bit about who we are. The Canadian Association of Radiology represents about 2,800 radiologists coast to coast, dedicated to medical and imaging excellence around the country. And we're going to talk somewhat about the lessons learned through the COVID-19 crisis. Where were we going in and where are we coming out, and what are the lessons learned? Plus some recommendations, two recommendations / asks at the end. I may have met some of you before through some of our days on the Hill in the last few years. And some of this information we're sharing is lessons learned from the Conference Board of Canada's report that was reported about a year or so ago that many of you have received through our national organization. For those of you unfamiliar with radiology, we're the physicians who are trained for about 15 years post-secondary, who diagnose and perform CAT scans, MRIs, ultrasounds, and do interventional procedures, more recently, astrology hospitals or hospitals that are community and radiology alike. But we also do other things like broken bones in the emergency rooms, low back pain with an MRI, and things like that. So many of you have probably used a radiologist or had interaction with a radiologist, and that's who we are. And I'm going to turn it over to Gilles, who's going to talk a little bit about our experience so far, and then I will close at the end. Gilles, yours from here.
Yes, thank you, Mike. So my name is Gilles Soulez. I'm an interventional radiologist at CHUM Hospital. I'm professor of radiology at Université de Montréal and the vice president of the Canadian Association of Radiologists. So thank you for listening us on this very important topic for the health of Canadians. So as you probably know, radiology and imaging is a gateway to our health system. Nowadays, almost all patients having a medical or surgical treatment will require diagnostic imaging and an imaging follow-up to monitor the efficacy
pardon me,
of the
Dr.
therapy.
Soulez, could you please hold your mic?
Okay. Is it better like that?
Yes, thank you.
Okay, sorry about that. So, as you know, COVID-19 related measures postpone diagnostic imaging for hundreds of thousands of Canadians, resulting in a 50% reduction in medical imaging services across the country. On top of that, non-urgent cancer screening was suspended. This has created a real sense of urgency, causing an overwhelming backlog in diagnostic imaging services. As you know, before that crisis, we already had extensive wait lists across the country compared to other countries. Prior to the pandemic, patients were waiting an average of 50 to 82 days for a CT scan and up to 89 days for an MRI, magnetic resonance imaging. Those waiting are 20 to 52 days longer than recommended. These wait lists for essential services are now much longer, putting the health of Canadians in dire straits. This is especially concerning for cancer patients who are awaiting a life-saving treatment that is dependent on medical imaging. The throughput in radiology department with the COVID crisis is currently estimated to be at 70% of the pre-COVID activities, mainly because of the disinfection and social distancing protocols. And this reality will stand us for a long period of time due to the eventuality of a second wave of the virus. As an example from Quebec City, a 20-year-old male patient presented with an abdominal pain. His physician filed a requisition for a CT scan at CHUM Hospital of Quebec City. Because of the backlog of the waiting list, he finally had his CT scan after 2 months as the pain was deteriorating. And a 20 centimeter large retroperitoneal lymphoma was found. Consequently, the chemotherapy was initiated with a significant delay, thus hampering his prognosis. At Quebec City, the MRI waiting list is very worrisome. There are currently 12,000 patients on the waiting list on MRI at CHUM Hospital. As discussed before, the throughput is currently estimated at 70% compared to the pre-COVID. They are working on eliminating less relevant examination on the waiting list. Even if they can eliminate 20% of those requisitions, the waiting list will rise still to 17,000 patients in 1 year, just to give you an example. In Alberta, they calculated that with the suspension of breast screening by mammography during the 2 last months, we already missed 250 cases of cancer that should be treated now. We understand that postponing non-urgent medical imaging services was necessary during the height of the pandemic. However, now that the first wave has passed and the spread of the virus had been contained, it's time to resume diagnostic imaging at its fullest capacity, but in a safe way. The health and the safety of Canadians is our #1 priority. We also respect the emotional well-being of patients and staff. The resumption of diagnostic imaging needs to happen in a planned, efficient, and safe manner, so as not to overwhelm the healthcare system and our healthcare workers. Our task force group on the resumption of radiology services recently provided guidelines to help radiology departments to resume medical imaging safely. It is a national emergency, given the already exhaustive wait times for these procedures, and incorporating the further delay that the pandemic has created will cause patients to wait even longer. Prior to the pandemic, it was estimated that in 2017, the economy lost $3.5 billion in GDP due to people being unable to work while waiting for medical imaging procedure. This will be substantially increased due to the COVID-19 crisis. For example, a 25% drop in patients being seen will result in an additional $1 billion of lost GDP, so close to $5 billion. Mike, I'll ask.
Thank you, Gilles, for going through some of those examples. As you can see, the committee can see that delays in some of this imaging, people are still frightened to come back to the emergency room or to the hospital just to get their tests done. And it's a real unnerving thing for people to come into the hospitals now. Most everybody is wearing masks. So it's we have 2 firm asks that we have that we're going to put to the committee or ask the committee. One you're familiar with that we've asked, I think, about a year or 2 ago, but a larger light has been shone on it. And that was the $1.5 million investment in medical imaging over 3 years to bring us up to speed with our G7 partners. We're about 9th in the world for advanced imaging with CT and MRI and some of the other high-tech procedures, and we're well behind other jurisdictions. COVID-19 has exacerbated that, and the $1.5 billion investment won't fix the whole wait list, but it'll be a strong start to get us in the right direction. On the lessons learned, we found that our infrastructure is quite dated nationally. There's not enough wait rooms, consultation rooms, spacing in the hospital, even things as simple as engineering like our air ventilation is 1970s without windows. And with COVID-19 and future pandemics, that's a real concern. So the CAR asks the committee to consider a large task force to look at not only the new equipment with the influx of patients, but waiting room spacing, additional cleaning, and mechanisms around to keep people safe during the pandemic. Lessons learned in conclusion, our healthcare system was not ready to deal with the demand. In the large urban centers in particular, Toronto, Montreal, to a lesser extent, Vancouver and Calgary, we didn't have the medical equipment or the staff to handle extended wait times and dealing with the acute onslaught of very sick patients. So we learned that. We also learned that our spacing was not strong, our PPE was not strong. We had a lot of deficits, but we've learned, and we'll learn from that going forward. So we're asking the federal government through your committee to support the resumption of imaging by making an investment through the federal transfers to look at new medical imaging equipment, to look at infrastructure, hiring additional radiologists, medical radiation technologists, sonographers in particular, to improve our quality care for our patients. That's our presentation. I believe there'll be questions later, but thanks again very much to the chairman of the committee for hearing us today.
Thank you, doctors. We go now to South Lake Regional Health Center. Ms. Christo, please go ahead. 10 minutes, please.
Thank you very much. I'll just give you a little bit of an introduction to South Lake and our role in Ontario, and then I wanted to talk about our experience with COVID-19. So we have over 525 beds. It is one of the largest hospitals in Ontario. We're located in Newmarket, which is 30 minutes north of Toronto, and we provide both community hospital services to a large catchment in York and Southern Simcoe, as well as regional tertiary programs such as cancer care and cardiac care. And we have the third largest cardiac program in Ontario. We've had quite an experience with COVID-19. We have seen in our GTA hospitals quite an impact. And that impact has taught us many lessons, and I'd like to talk a little bit about those lessons and then also what some of the bright sides of this has been. So just to give you an example of where we've been, we initiated an incident management team and an emergency operations center in late January. This was earlier than most, and that was very helpful to us because we started to anticipate the kinds of things that we would have to get up and running. We had a daily emergency operation center meeting. We staffed that for many hours a day, and we had many managers and administrators and physician leaders and others working many hours. We held daily town halls with staff and sent out a lot of information to our staff, and there's no question that transparency and communication at both a local level, at a provincial level, and at a federal level have made a big difference through this pandemic response. One of the things that we did is that we were very transparent in posting our volumes, our what kind of personal protective equipment inventory we had, and our projections. And we developed a logistic regression model to project demand for intensive care unit beds and also modeled the local epidemiological reproduction rate in our catchment areas to support our response. We had our first patient in the ICU on March 16th, which was 5 days after the pandemic was declared by the WHO. And as of today, we've had 88 patients with COVID-19 admitted to our ICU and our wards, and we have unfortunately had 22 deaths. Starting in mid-March, we developed a drive-through assessment center, and we've tested literally thousands of patients, both at that center and as outreach to our long-term care and retirement homes and congregate settings within our catchment. And we most recently have become one of the first two hospitals in Ontario that were ordered by the Ministry of Long-Term Care under a mandatory management order to take over the management of a long-term care home in outbreak. So with that as the background, I wanted to talk about a few things that were our biggest challenges and where we believe that the federal government can have some role. The first one is in procurement, supply chains, and PPE. And there is no question that one of the most stressful aspects of COVID-19 and our response has been PPE availability. It's clear that our current just-in-time procurement and delivery approach in Ontario, and I know that that is pretty common throughout the provinces, I've also spent a lot of my career in BC, need to be fundamentally reviewed. The pandemic stockpiles that were present in some provinces, including Ontario, and federally, that were in place for SARS were allowed to expire. That was not only resulted in a lot of expensive stock not being able to be used, but it also created a scenario where we were critically short when we should have been prepared. And one of the recommendations we have around that is that the federal government and the provinces work together to rotate pandemic stock with the regular supply chain to prevent expiry so that we will be ready the next time something like this happens. The amount, those shortages created not only sleepless nights, but also created a lot of challenge around the time and effort to manage, count, order, go back and forth with central supply chain, numerous vendors directly to reconcile and model our PPE supply. This was a massive, massive amount of labor and time. And the churn of changes in terms of strategy and approach to PPE left a lot of significant levels of stress and morale. So I think we have to really study what we've done with that and to make some changes for the future. Long-term care is the other area where I have some advice and counsel, and that is that we have known, I think, for many years that the long-term care model that we have in Ontario, but also across other jurisdictions in other provinces, has significant flaws, and those were clearly illuminated during COVID-19. A lack of sufficient oversight, inspection, and integration with the rest of the system have created substantial issues for many homes. Many of these homes are very outdated. They are very old and they are very crowded, and it is almost impossible to prevent outbreaks in these situations. There is a lack of training for staff. There is a lack of staff in some cases. There is a lack of management capacity in many cases. And one of the things that I think would be a help is to have some national standards for long-term care, very similarly to what we have in some other hospital jurisdictions. And we also need some very fast capital investments. Many of these homes just simply cannot operate the way that they need to operate during outbreak because of their size and because of their the problems they have with infection control. And lastly, I just want to talk about hospital capacity. And there's no doubt that hospitals across Canada, it doesn't matter what province you're in, have been working over 100% capacity well before COVID-19. And further to my colleagues with my radiologist colleagues, one of the challenges with working over capacity is that the only way you can recoup capacity to deal with a pandemic like this is to cancel elective procedures. And at our hospital, we went down to 30% of our normal volume rate. And we've modeled that for hip and knee replacements alone, it could take us 7 years to recoup the amount of surgeries that we would need to do if we don't work evenings and weekends and everything else. And the problem, of course, with that is human resources. And as one of my other colleagues mentioned, they are pretty burned out, and to try and get them to work those extra hours, even if we were funded for it, would be very difficult. So once again, I think that we need to really rethink our hospital sector. Now, bright spots, and very quickly, I'll just mention, virtual care has been a real bright spot. I think after years of painfully slow uptake in Ontario, and I would say other provinces, this pandemic triggered widespread adoption of virtual care. And what we realize now is that we don't need to go back to exactly the way we were doing things. We will be able to convert a substantial number of visits, particularly ambulatory visits, to virtual care. I think what we've also noticed is that the good collaboration that we at least have had between the hospital sector and some of the other sectors has helped us, but that is not widespread, and that there needs to be some moving toward a better integration across all provinces and certainly within all sectors. But certainly that amount of integration, and something that we had here in Ontario through Ontario Health Teams, was very helpful. And lastly, and this is, I think, just a very big thank you to our communities, because throughout this pandemic, our staff and physicians have been continually bolstered by an unprecedented outpouring of support from the communities we serve. And, you know, for people who are very, very tired and overwhelmed, and in some cases actually experiencing some level of PTSD, that amount of support was incredibly helpful, and we were incredibly grateful for it. So I will leave it at that and wait for questions.
Thank you. So we'll start our questioning now. We will do 2 rounds of questions. We will start the first round with Mr. General. Mr. General, please go ahead. 6 minutes, please.
Thank you, Mr. Chair, and thank you everybody for all the work that you're doing in your work lives, but also for joining us here at committee today. Obviously, very important to see where we want to go, any potential waves or any other potential other pandemics. So again, thank you for your time. I do quickly want to ask Dr. Liu the first question. When it comes to, you made some comments about the vaccine. Would you agree that the Government of Canada is doing all it can right now to be at the table for a vaccine?
Mr. Chair, so on the question on vaccine, does Canada do all it can to be there? I think there's massive, I would say, investment right now. I think the issue is the concern about the diversity of the investment. That's one thing. And then the other concern is making sure that we are following through the money that we have invested, and then that meaning that when we invest such a massive amount, and the reality is that on Gavi it's on regular vaccination, but it still gave a better voice. Then we need to make sure that we have a strategy and then recommendation about R&D and how it will be used. And then right now I'm not totally convinced that the follow through is done. There's no, but maybe it's done and it's not yet public. But I think that this is something that needs to be followed through.
Thank you, Dr. Liu. Would agree. I think there's certainly on the transparency front, we're not seeing if it's available or not right now. Only because I have a limited amount of time, want to move to Dr. Soulez and Dr. Berry. We heard of the delay in the number of screenings. I think you said 20 to 52 days later than recommended, Dr. Soulez. One of the conference board recommendations was to spend money to replace the aging machines and buy new ones. And you mentioned that as one of your asks. How much would that help? Do you have the data available in terms of help that backlog in terms of getting caught up? Is this in case you reference the 250 cases in Alberta? Are there others that out there that we could be helping with these machines? I think you muted, Dr. Soulez.
Yeah, it's very important in the sense that the hit of the COVID-19 crisis really decreased our capacity to exploit our unit as before. So for one unit, let's say we was able to do 80 patients a day. Now we are doing 60 patients a day. And we are not sure it will change in a short delay, as the issue raised by Dr. Liu, that we may have a second hit, but also other infection can change. And I believe for all the high throughput, procedures, we need to change the way we are doing them. So we have two ways to increase our capacity. First, the capital investment, as raised by Dr. Berry, so increase the number of units, because we cannot do the same amount as before. In Canada, we are the most productive radiologist for one unit compared to US. It's really a big difference. Second, to extend the operation time. So it means that we need more personnel, more resources. Third, we need also to install all the waiting rooms to be sure that we are safe. So we have really some important measures to do so. So Mike, if you want to comment on that.
It's really difficult to know how long it would take to catch up because we're still in it. And as Jill has said, we could have a second wave and a third wave, and it's been mentioned on the call as well. So we are running at about 70% capacity. We might get to 80% but within a year. We might slip back to 60 for a while. I don't think we'll go back to 30% because of lessons learned. Because our product, it takes what it used to take 10 minutes to do a CAT scan, now it takes 30. It used to take half an hour to do an ultrasound, now it takes 60 minutes. The turnover takes time with cleaning. So I think we're going to be in this for a long time, and as we redefine how we're going to improve our productivity. In the meantime, our wait list will probably, we'll try to slow the wait list. I don't think we're going to catch up to our OECD countries in a hurry with a significant investment with capital. And as Jill says, HR resources. And I think it's also been mentioned on the call by others too. So a real challenge.
I think I have about 15 seconds. Sorry, I just want to quickly get to your comments. If you're familiar with the Synaptive 0.5 T MRI at the QE2 Health Center, where they're beginning to study the COVID-19 patients' brains and hope to learn more about the virus. Familiar with the study, and perhaps comment on the potential of that study?
I'm familiar with the scanner, unfamiliar with the study, but interesting work. But we'll keep an eye on it. But we can find out more for you if you like through the office, through Nick Neuheimer, our CEO in Ottawa.
That'll be helpful. And thanks, Chair.
Thank you, Mr. General. We go now to Dr. Pawlowski. Dr. Pawlowski, go ahead, please. 6 minutes.
Thank you. My questions are primarily for Dr. Liu, and I guess a little bit also for Ms. Crystal. Now, Dr. Liu, you can correct me if I'm wrong, but you kind of have two hats. You work for Médecins Sans Frontières. You've done work on epidemics, public health, but you are also currently an emergency room doctor in Montreal. Am I not correct with that?
Yes, I'm an ER doctor now in Montreal, but I'm not with MSF anymore. But yes, I have still communication with them.
Okay, so given your two hats, I think you're a good person to answer this question. It would seem to me that in Canada we're becoming two countries in terms of COVID-19. There are places like Thunder Bay, and I'd suggest the vast areas of Canada, most of Canada, where we have really limited number of cases. The incidence is low. Our testing capacity is getting pretty good. Basically, we're managing, whereas metropolitan Toronto and metropolitan Montreal are a different story. There still seems to be large numbers of cases. They don't really seem to have it under control. So one, I wanted to ask, why the difference? Why is Montreal and Toronto not getting this under control? The second part of the question, to allow hopefully both of you to get a response in there, is as long as Montreal and Toronto, it continues to circulate. As we start to open up, if we allow people to travel from Montreal and Toronto, there's going to be the threat throughout Canada, including, as Dr. Liu, I think you know, northern Indigenous communities. Should it get into those communities, given their socioeconomic problems, their lack of healthcare, it's going to be a real problem. So the question is, what can Montreal and Toronto do to do better at getting it under control? Should there be some mandatory use of masks, particularly in mass transit? And what can we in the rest of Canada do to help Montreal and Toronto get this under control? So maybe I could start with Dr. Liu and then Ms. Crystal. Thanks.
So, Mr. Chair, with respect to the two countries, I think that this is not an unusual, I would say, scenario. In many places, when you have an epidemic, you have epicenter, and then we have other spots where it's not as, I would say, as severe in terms of number of cases. Why the difference? I wish I could answer this question, Mr. Chair, for the committee. I think most of the time it's a multifactorial, I would say, environment, and at this stage, I think we're going to need to have much more, I would say, we're going to need to take a step back to figure it out. But what we've seen is the fact that we know that in some places, and especially with the long-term care facilities, that they became a center of amplification, that having a healthcare worker moving from one working in more than one places end up adding to the contamination and transmission, community transmission. So there is at least some of that. And then there is this thing about the timing of and the influx of people who came in straight from the beginning. And these are all assumptions, when people came back from the week off, the break, and then the fact there was no big follow through on people who were coming in. I know that I came back on mid-March. Nobody asked my name. I just walked in. They gave me a pamphlet. I went home. It was up to me to do my quarantine. So I think that it's just going to need much more investigation than me just saying, my opinion. But I think it's going to be multifactorial, and it's the addition of all those little things that make it a recipe for disaster, plus the density of the population in Toronto and Montreal.
And what can you do in order to try to get it under control? How about mandatory masks, for example, in mass transit?
Yes. So, Mr. Chair, about the mask, I think this is something that I have a bias for that, because I think that when you look at the experience of other countries, especially in Asia, this is something that has been imposed, but it's as well part of the culture to a certain extent, if I may say that. But the reality is, I think that our incurrence message on masks has been hard to foster for compliance. And now we want to be stronger on the message, and it's difficult to implement. But yes, I think that my personal view, which is not based on more than my personal view, is I think having in public transport or in closed, I would say, public space, the mandatory, I would say, use of masks might be helpful. Nothing is perfect. In this kind of scenario, unprecedented pandemic, we always going to deal with imperfect solution to implement. And that's normal, and we need to accept that. And then mask is not a magic wand, but it will contribute. It might only decrease by 10%, 15%, but it will decrease, and that would be helpful.
Okay, Ms. Crystal.
Thank you, Dr. Pawlowski. We go now to Mr. Thériault. Mr. Thériault, please go ahead. 6 minutes, please.
Oui, merci.
Yes, thank you, Chair. I would like to thank the witnesses for what they've been sharing with us here. They will surely be able to help us find solutions thanks to what
Mr. Pawlowski
Mr.
asked a brief question that I wanted to ask, because when Dr. Squash and Tremblay appeared, they said that they found it justified that in Montreal there was a decision to, with respect to the masks worn when taking public transit. You said earlier, I believe on April 15th, this was mentioned. We still don't know very much about the virus. We don't have a vaccine. We don't have any antivirals. We aren't self-sufficient. The screening services have variable geometries. Traceability is relative. So we're condemned to manage time and space, as you said, with tempering measures. And when you appeared the last time, you said you were concerned about what might happen with a second wave and ill-advised lockdowns, and you wanted the health system to be able to provide services to non-COVID patients, and this was mentioned by the radiologists. You also mentioned that we should prepare for a second wave by preparing more distance between the cold and the hot zones. So I'd like to know, is there a strategy? Is there a plan? Are we ready for the fall? Is there any type of action plan that would allow us to be more proactive rather than reactive? I think that would be the key to what is to follow. Mr. Chairman, are we ready for a second wave? Well, that's the question of the hour, if you will. It's very difficult to respond because what we are witnessing now is that recommendations are somewhat tempered. There's hesitancy, and I think it's very difficult because we're trying to serve all masters, if you will. We are comparing lockdown to economic recovery, and this creates confusion with the public. So,
yes, please. Thank you.
Sorry. Excusez-moi, Monsieur Chair.
I apologize, Mr. Chairman. With respect to preparedness, it's a difficult question because people are wanting the economy to get going again. They want the lockdown to end, and I don't know whether we're really working towards preparation for a micro outbreak that could happen during the summer or a second wave. I'm not part of the planning. I don't know what is being done in terms of preparation, but I have the impression that there's a greater focus on removing the lockdown and relaunching the economy than preparing to respond to a micro surge or a second wave. This is what I'm witnessing as a citizen. Well, you appeared on April 15th, almost 2 months ago, 2 months less 5 days. So in a pandemic, 2 months less 5 days is an eternity because so many things have happened. So I'd like to thank you for appearing today because it's important to have a follow-up, and it's important for your great experience to enlighten us. Now, in 2 months less 5 days, all of these issues that you raised, the hot zones, the cold zones, trying to keep some type of separation between them, do you think there's any hope that that will happen? Because we have time to provide for the worst that could happen with a second wave. So do you think that anything is being done in that regard? Is there anything more proactive underway? Because now we're reacting, and cross-contamination is what has caused a certain level of disaster. Mr. Chairman, with respect to the the cold zones and the hot zones, what's unfortunate is that strategies change as community spread changes. Today, community spread is high, and when community spread is high, it's more difficult to have a cold zone or cold patients, if you will, and the dynamic would mean that anyone could catch COVID-19, so it's all warm. Now, and zones become very difficult because there's a lack of space. So the concern is that what would have been ideal would be to have a COVID positive hospital and a COVID negative hospital, but they decided to find a median measure, and we know what happened. Now, in rural areas that could be affected but aren't necessarily affected now, it would be important to have a cold zone and a hot zone. This is being done for intensive care in Montreal, but we've realized that it's very difficult to respect all of these protocols. That's why we had 8 micro spreads in Montreal.
Now to Mr. Davies. Mr. Davies, go ahead. 6 minutes, please.
Thank you, Mr. Chair. Thank you to all the witnesses. Dr. Liu, good to see you back. I'll begin with you. Dr. Liu, last week in an interview, you stated we need a testing strategy. We need to establish our testing priorities. It seems that every expert and researcher that comes to our committee tells us that having a rigorous testing and contact tracing capacity and program is essential to our ability to control COVID-19. Yet we can't seem to ramp up testing beyond about 30,000 tests a day, far below our capacity. Can you tell us whether you think we're testing enough, where, if we're not, where the barriers are, and what your suggestions for a good testing strategy would be?
Mr. Chair, thank you very much for the question on testing. Everybody see the necessity to have a testing strategy, especially in the reality that, especially a few weeks ago, we were in the reality of not having enough tests to be given. We have not ramped up to the extent that we wanted to, but the thing is, if we still are limited by the number of tests that we can do, and I think that we still are to a certain extent, then we need a strategy and we need to prioritize. And who should we prioritize? And we should prioritize the people that we think can be vector of COVID-19. And then for me, what has been missing since the beginning is that we never had the prioritization of testing the frontline worker. And I still do not understand that. This is something that in all the epidemic I've worked in the past, we always made it available and readily available, and especially when we knew that there were some asymptomatic cases. Whereas for Ebola, it's not exactly the same. But just to say that we know there's asymptomatic, we know there's pre-symptomatic, and so therefore I will advise frontline workers to be tested regularly to make sure that they are not going around, and we don't have a case like in Campbellton where we have a doctor who's positive and we end up exposing more than 150 people, and then there's at least 16 people who are part of that chain of transmission.
Thank you. Now you also mentioned that you thought it would be prudent if we get ahead of hopefully a potential vaccine and start thinking now about how we would approach vaccinating Canadians. Do you have any suggestions at this early stage about how we would prioritize access to vaccine if and when we develop one?
So, Mr. Chair, about the strategy on vaccination, I think I alluded in my short intervention, but I think that from all the experience I have from other pandemic and regional epidemic, we always, I would say, prioritize the frontline worker. The reason why is if they fall, we have no one else to care for the patient. So that for me would be a must. And then after that, knowing that if it's feasible and advisable and safe, I think the vulnerable community, because we know that the elder have been very, very I would say vulnerable to COVID-19. And then if they could sustain vaccination, I think that we should think about them. But probably any, I would say, subpopulation that live in a vulnerable situation probably should be prioritized as being vaccinated.
No, if I can drill into that, there's been some talk recently about us not keeping data on racialized communities or Indigenous populations or other populations that it's been postulated may be more vulnerable to COVID-19. Do you think we should be gathering data on sort of subgroups for that purpose of developing an idea of where the vulnerabilities are, say for purposes of determining access to vaccination in priority?
So, Mr. Chair, about getting data on people and then on sub community, I think that this is a question that it's about personal private information, and I think that's possibly would be feasible if we were to ask people if they are willing to give their information and be part of I would say depository of data.
Okay, my final question to you, Dr. Liu. You mentioned the importance of Canada having a seat at the or which table you were referring to.
Well, so Mr. Chair, about Canada and being having a seat at the table is right now there's been different, I would say, high governance platform in terms of R&D. For example, the WHO blueprint. For example, in different board of big NGO like Gavi, Canada is there, but CEPI, the Coalition for the Epidemic Preparedness Initiative, where Canada has pledged $2 million, add another, I think, $2 million. But then it could have been, it could be advisable that since this is a consortium of development of vaccine, to make sure that we influence, because right now they have more than 10 candidates who probably one of them is going to go to the finish line. So when we know there is those sort of opportunity of deliverable, and then Canada has been already investing, then they should make wave and say I'm present and invest more in terms of presence to be able to influence the outcome.
Thank you, Ms. Crystal.
Thank you, Mr. David.
Mr. Chair. Thank you.
And that ends round one. We start now with round two with Dr. Kitchen. Dr. Kitchen, please go ahead, 5 minutes.
Thank you, Mr. Chair, and thank you everybody for being here. And Dr. Barry, I suspect that most people listening to this conversation, Canadians, would think, as a radiologist, they're going to think maybe X-rays, they might think MRIs, and maybe they might throw in ultrasound, but they don't realize the many other aspects that the radiologists provide for Canadians in healthcare in issues such as CT scans, echocardiography, PET scans, tomographies, radioisotope scans, spectra scans, all these things that are such huge amounts that are looking after Canadians' health. So I appreciate and I thank you for your recommendations. And I'm sure you might be aware or not, but last year during the election, our part of the Conservative platform was to propose a $1.5 billion investment in purchasing MRIs and CT scan machines to replace the aging equipment. And I'm glad to see that is part of your recommendation. That number is familiar and very helpful. I'm interested to know, though, what data is the Canadian Association of Radiologists using to determine how best to alter their practices to ensure the safety of both employees and patients?
Go ahead.
This is a real-time story, really. So the data that we have is empirical, but we've done 12 publications since the beginning of COVID-19 over 12 weeks. The most recent, probably the most comprehensive article that we've done is the reentry task force that was chaired by Dr. Anderson, and Dr. Soulé was on it, the national committee looking at the impact of reduction of services down to 20-30% and the slow reintroduction. A lot of it's empirical on the fly, hard to get data at the best of time, let alone in real time. But we do have a pretty strong network through the office and nationally to know where most provinces are, where most major metropolitan areas are when it comes to their ability to ramp up the system.
Would you be using PHAC data? And if so, do you feel that you're getting that in a very timely manner?
What is PHAC data? Excuse me.
The Public Health Agency of Canada.
Okay, Jill, go ahead.
Yeah, if I may comment, so with the task force, we really have reviewed, all the recommendations worldwide. So US, Europe, China, and basically we try to adapt those recommendations to the Canadian reality. So our throughput, our equipment, and it's very difficult to say, let's say an example, air exchange. Air exchange is very important, for COVID prevention. So those data are based on good science. So we know that the cycle of ventilation we need between each patient, and if you have a patient with COVID. So this kind of data.
So I'm taking it that the PHAC has not been in contact with your organization at all. Am I understanding that?
So basically, it's based on recommendation from all radiological societies across the country.
Okay, but they haven't reached out to you to provide information that might pertain to radiological services, et cetera, across the country?
We have very close collaboration with the American College of Radiology, with the French Society of Radiology. So we really have, Concord and exchange. So this is a close relationship. Yeah.
Thank you. May I take it
we
then
did.
that
we did have some coordination, according to my office. We did have coordination with PHAC, which is not I'm not familiar with, but public health, and with CADF. We had federal agencies on our task force reentry. That's your answer to the question.
Thank you very much. Ms. Crystal, I appreciate your presentation. And, South Lake Regional Health Center, and I had to look that up. I knew it as York County, and I spent many times there when I was a student at St. Andrews College. And in fact, York County was where my life was saved when I was the victim of a hit and run. And then that was the first hospital I went to before they sent me to sick kids at 16 years of age. So I have a great admiration for that hospital, and it's always someplace in my heart. Now, you mentioned, and I think all three organizations talked a lot about being lack of preparedness that we've had for this COVID virus. And it's interesting to hear because when I hear you talk about lack of preparedness, I think I hear you talking about the need to where we should have been doing, being proactive instead of reactive, and having testing procedures, protocols, procedures, simulation tests, et cetera. Would you agree with that?
Well, partly yes and partly no, I guess, Mr. Chair. I would say that certainly from a personal protective equipment point of view, and from a pandemic preparedness point of view, I think there is some room for improvement for sure. And I certainly mentioned that in my opening comments around pandemic supplies that were put in with SARS that expired, et cetera. However, remember that this is a unique virus. So to try and develop some of the testing protocols, we kind of had to do it on the fly because it was something new, and we didn't even know how we would be able to test for it. The test actually is not an easy test, and so one of the things that people I think is that they can do something simple and go in for a test. When they come in and they get that nasal swab and it goes very, very deep, it is not a pleasant activity. And so we have a lot of availability of testing. We don't always have people who want to come and get tested. So there is
and I'm not sorry for interrupting you.
Thank you, Dr. Kitchen.
Okay.
Thank you. We go now to Ms. Sidhu. Ms. Sidhu, go ahead, 5 minutes.
Thank you, Chair. Thank you all the witnesses for joining us with us today. My question is to Ms. Crystal, and I want to talk about long-term care facilities, even though it comes under provincial jurisdiction. On 24th meeting of the Health Committee, a region of Peel CEO Nancy Polsinelli testified about the long-term care homes that the region managed. She discussed how the region has approached managing its homes during the COVID-19 pandemic. In your opinion, as someone whose hospital has taken over management of a private long-term care facility, is there a difference in the quality of care in private long-term care homes compared to the public option?
Well, there's so I've had experience both in the BC sector for many years as well as here in Ontario. And one of the things that I did notice that I think made some improvements in the BC sector was the fact that all private and public homes were still connected to the regional health authority and were directly contracted, if you will, with specific contractual obligations around quality standards and staffing ratios and those kinds of things. So that clearly helps. And I think there is some evidence to suggest that here in Ontario and in other provinces, that private homes do have a tendency to have lower staffing levels, particularly the smaller private homes that do not have the large infrastructure that some of the larger cross-Canada companies have. And certainly our experience has been that there has been a lack of infrastructure in teaching and training, in purchase of personal protective equipment, and in infection control practices that really did put them in a one-down situation going into this pandemic.
On your statement, lack of staff, and we have a CEO of William Osler Hospital, which is from Peel, Dr. Naveed Muhammad, testified success of our local temporary program to allow foreign trained medical experts to work in the health system on the front line to mitigate the shortage. On top of preventing burnout among permanent medical staff, the program allowed foreign trained specialists to get the necessary experience in our healthcare system. What is your perspective on this solution?
Well, I think it's a solution to potentially another problem. Our experience, and I can speak from my experience and our local experience, is that we can actually hire people, but the structure for their hiring, so the people exist, but right now the job market is such that many of the private homes don't offer full-time positions. Some of the home health agencies don't offer full-time positions for personal support workers, and that creates a situation where they job hop and they work at multiple organizations. And we saw during this pandemic that PSWs working at multiple organizations were a definite vector for the spread of COVID-19. So in some cases, it isn't necessarily about we need to go outside to hire. It's that we have to improve the conditions for our own people who are ready to be hired, but they simply can't work properly within the structures that we have provided for them.
Thank you. Mr. Chair, do we have more time?
You have a minute and a half.
Okay. And you also talked about the virtual care. How you think it's a beneficial for Ontario or the residents?
Well, I think in the long-term care sector, it can be very beneficial to connect some of those patients to some of the specialties that otherwise would not have the bandwidth to be able to visit in person. So people like palliative care, specialty geriatricians, and in many cases, mental health professionals. And in the hospital sector, what we found is that certainly a fairly big number of people can be seen at home. So for example, we used to bring people in to do pre-op assessments. There's no reason why we can't do that virtually with someone in their home. In many cases, a lot of post-operative assessments don't necessarily have to require the patient to come into the hospital. We can use the virtual care that is available, and there are many platforms available. And COVID-19 and the pressure of that allowed for some very rapid trialing and testing of some of these solutions which worked. So we essentially kind of cut the bureaucracy, if you will, and jumped right to solution into trialing things and found out that they worked.
And
thank you, Ms. Sidhu.
Thanks.
So we go now to Ms. McLeod. Ms. McLeod, please go ahead. 5 minutes, please.
Thank you, Chair, and it's certainly a pleasure to join you. I know the committee's been working very hard for quite a while now. So my focus for my questions will start with, I think we have a bit of a window right now to either prepare for what was being said was microbursts or a second wave, especially as it relates to the long-term care homes. You know, I know many people talk about national standards, but I would suspect if you looked at the Community Care Facility Licensing Act in every single province and territory, you know, the standards are there and they would be remarkably similar. So I'm more concerned with sort of what are we doing right now? So I guess my first question, and perhaps Ms. Crystal could give me a sense of, in Ontario, is every facility having, you know, both a health, safety, and an infection control inspection? Because to me, every single facility across the country should, you know, it would make sense to be having a complete and thorough assessment as sort of step one. Is that happening at all?
Thank you, Mr. Chair. The question is a hard one for me to answer everywhere in the province, but what I can tell you is that in our experience, we believe with the particular home that we took over, there were some inspections, there were some violations to the standards, and there wasn't always the, I would say, rapid follow-up to ensure a rapid improvement cycle to address the inadequacies. And I think that probably is the case across the province. And I think that we have some lack of integration in the system in Ontario, where public health is the person charged to look at some of the community structures that need to be inspected, some of the quality standards. The Ministry of Long-Term Care is responsible for inspecting other ones. And so I think that there has been a disconnect and a lack of integration in rapidly detecting problems and in rapidly addressing them.
Yeah. So perhaps, you know, that would be a good first step, with dollars perhaps being allocated for some of the capital issues that might be identified. I think that's got to be an important second step. Would you say that, first of all, has the PPE issues, you talk about the real challenges, do you have a sense that the whole flow is getting better? And do the people that work in these facilities have adequate and proper training? And is that something that needs a focus right now in terms of PPE?
Thank you for the question. So we have had a better flow of PPE over the last month or so, for sure. I think there is still it is still somewhat tenuous, especially as we ramp up or start to try to ramp up some of our elective and scheduled procedures throughout the system. That will put a drain on some of the PPE. In the homes themselves, certainly I can speak for my experience, and I can speak to probably some of the experiences of my colleagues, which was in some of the cases they actually did have PPE, but they didn't have the right PPE. They were not using it properly. They were not trained to use it. In some cases, they were using 2 masks, thinking that that would help to protect them when all it did was waste a mask. They didn't always have face shields, and gowns, didn't always change their gowns. So there was and remains to be a lot of work to be done around education and training. And that can't just happen in a one-time shot. Even in a hospital that is very prepared, we set up a PPE headquarters, and we had people working around the clock as what we call PPE observers. And these are people who would watch you put on and off, don and doff, as we call it, your PPE. And that's really important because many of the staff positives come from taking off your personal protective equipment and taking it off improperly and contaminating yourself. Okay, and I believe that's a factor.
Thank you, Ms. McLeod. We go now to Mr. Van Bynen. Mr. Van Bynen, please go ahead, 5 minutes.
Well, thank you, Mr. Chair, and thank you to all the witnesses for joining us today. It's great to be able to welcome a local witness to the committee. So I'll be focusing my questions to Ms. Crystal, and it's largely because I've been able to see the challenges that she's need to deal with in a rapidly growing community, and the resources of the hospital for the last 9 years that I've seen have been extremely stressed. But my question to her would be, when you're facing a growing community like this, how do you create and how do you protect surge capacity?
Well, that's the probably $1 billion question, and so it is very challenging. The only way we've been able to create surge capacity is by reducing elective and scheduled activity. And of course, that has a very deleterious effect on all of the people on wait lists waiting for surgeries. And in particular, not people necessarily waiting for the things that we would all recognize as very life-threatening conditions, such as cancer or cardiac, but absolutely for people who are waiting for hip replacements, knee replacements, various types of surgeries that are considered quote unquote elective, but which create undue hardship and pain for people while they're waiting on the wait list. So unfortunately, those have been the ways that all hospitals across Canada have found their surge capacity. And that's very challenging. And remember as well that hospitals struggle with something called ALC, which is alternative level of care patients. And these typically are patients waiting for admission to long-term care homes and others. And of course, with the long-term care homes all on outbreak, we have a bit of a double whammy going on right now.
Great, thank you. We've also heard from other witnesses that their recommendation was to put the treatment of COVID patients and take them away from the emerge in the hospital. And I see that on May the 9th, CTV's W5 featured a special edition that broadcast an exclusive look inside of South Lake's COVID CID to showcase the challenges that were faced on the front line. Could you share with the committee what some of those challenges are and how South Lake was working to overcome them?
Yeah, I mean, some of those I addressed in my opening statement, things like personal protective equipment availability in the supply chain. I think, rapidly quick planning for increased capacity, ramping down your surgeries, trying to discharge patients, developing an assessment center. But there were a lot of medical unknowns. This was a novel virus, never seen before. There was a lot of fear in our staff and in the communities, which we had to address, and no known treatments. And so, you test and try on the fly. And we used an awful lot of international experience to guide us, and certainly collaborated a great deal with colleagues. I think those are the main challenges. Human resource-wise, I think we did quite well.
Good. Thank you. I know that COVID-19 has had a significant impact on the mental health of Canadians, and that South Lake offers a wide range of mental health services to assist individuals. Has there been a change in the number of individuals seeking assistance from South Lake since the beginning of the pandemic?
Well, interestingly, although I would agree with you that there's no question that living through this pandemic has created certainly an increase in anxiety and depression among not only healthcare workers and others, but just people dealing with these things in the community. But interestingly, our mental health ED visits were down 48%. And I think that was because of the fear factor of people not feeling comfortable going to the emergency department. Having said that, we were also providing a great deal of service virtually to be able to get out to people who wouldn't feel comfortable coming in.
I know that a lot of our questions are to determine how well or how has the government responded. I believe that we're living in a very small universe with a lot of mobility, and so my question is, beyond what you've already explained, is there a way that we could build back better, assuming that there's likely going to be, if not a resurgence of this, but another pandemic that we're going to need to face based largely on how global we are? What would your recommendation be beyond what we've seen?
Well, I think that one of my colleagues earlier mentioned that when she came in through the airport, she received a pamphlet, and that was in mid-March. And I was hearing those stories actually well into the end of March. I do think that one of the things that we could get better at is screening visitors, and screening. You know, we've begun screening absolutely everyone who comes into the hospital. I'm not convinced that's going to be a short-term phenomenon just during the pandemic. That may well become part of our norm so that we can not only use those opportunities to keep patients and staff safe, but also use those as teaching opportunities and reminding people to do things simple like washing their hands.
Thank you. Thank you, Mr. Van Bynen. We go now to Monsieur Désolé. Monsieur Désolé, allez-y, s'il vous plaît, 2 minutes et demie.
Merci, monsieur.
Thank you, Mr. Chairman. And I'd like to thank all of the witnesses. You've been very enlightening, and this is extremely important to us. My question would be to Dr. Liu. You referred to the importance of best practices. You're very familiar with Quebec, so I'd like to know whether you could tell us, in the context of a second wave, what best practices should we advocate and bring forward, especially with respect to the long-term care homes in Quebec. Mr. Chairman, with respect to best practices, especially in these long-term care homes or seniors' homes, I think the problem was in the fact that the protection of a vulnerable public meant that the visits were stopped, and the principle of reciprocity means that people in these centers, in these homes, should be well fed, should be properly taken care of, both mentally and in terms of their health and their socialization. And that's where the problem was. That's one point, and that is there was no reciprocity with respect to this vulnerable population that was to be protected. Now, with the staff and the people who live in these homes, there was not the testing wasn't done quickly enough, isolation wasn't done quickly enough, the staff wasn't protected, and these homes were understaffed. And these are the four things that we can master and we can adjust. Second question to you, once again, Dr. Liu, what is the greatest concern to you if there is a second wave? Well, what am I most concerned about with respect to a second wave? It's to not be able to ramp up in reaction, because when it happens, it would take a few weeks, and at that time, all of our good habits to minimize transmission, that is distancing, hand washing, wearing the mask, this will be a challenge that will continue. We have to maintain these practices, and also with respect to hospitals, they have to be prepared, but notwithstanding that, there were 8 outbreaks in the hospitals despite the preparation, and in my opinion, that shouldn't happen with a second wave. We have to be ironclad when controlling infection, and all the procurement problems, the PPE problems, these should no longer be an issue because they will be settled and taken care of, and our staff will have to be confident that they won't be lacking in any of this equipment. Even today, I go to Sainte-Justine, and they're still counting masks. And I have to ask the head nurse for a mask. It isn't self-serve. So there's still this fear of not having enough equipment. Thank you. Do I still have any time, Mr. Chairman?
Go ahead, Mr. Davies. Mr. Davies, you have 2.5 minutes.
Thank you, Ms. Crystal. On May 25th, the Ontario government issued mandatory management orders appointing local hospitals to temporarily manage 2 of the province's long-term care homes for 90 days. And of course, South Lake Regional Health Centre was appointed to manage River Glen Haven Nursing Home in Sutton, Ontario. That was a for-profit facility that has seen at least 102 infections and 32 lives claimed by COVID-19. We've seen similar things happen in British Columbia, where the government had to take over private care homes. In your view, why was River Glen Haven unable to control the spread of COVID-19?
Well, I mentioned, thank you for the question. I mentioned, I think earlier in my general comments about some of the older homes and some of the challenges they have with 4-bed, 3-bed rooms. And so River Glen Haven is an older home. And what we found is that some of the rooms, there were, maybe a foot between beds. And that is a very difficult situation in order to try to contain somebody who maybe have positive COVID status. And we also found that although they had some PPE, that the staff were not wearing the PPE appropriately. So to your question about why there was a difference between profit and nonprofit, it's, my answer would be that I can only assume that that there is more of a concentration on the cost of preparation at a for-profit than there would be at a nonprofit, and I think that some of the homes, and I would say River Glen probably fits into that category, are funded for more beds than probably what that older home can realistically house and contain.
Well, it would seem to me that even without COVID-19, warehousing seniors with a foot distance between them, with a vulnerable population and all manners of infections and comorbidities would probably not be a good idea, even before COVID-19. I was intrigued as well by your comment about national standards.
Mr. Davies, you're at 2:38. Could you just be quick, very quick?
Sure. Can you elaborate a little bit on what you'd like to see in national standards? You mentioned similar to other types of healthcare delivery. What would you like to see in the long-term care sector with respect to national standards?
Well, I mean, I would like to see a specific hours of care per patient day, and each province has some differences there. I've worked both in BC and in Ontario, and the integrated model in BC, I do think, was an advantage in enforcing those types of standards.
Great, thank you very much. That brings round 2 to a close, and it also brings this panel to a close as well. So I'd like to thank all of the members of our panel for sharing with us their time today, and all the great information that you've given us and shared with us. And with that, we will suspend for a few minutes while we bring in the next panel. So thanks a lot, everyone. Welcome back to the meeting. And for the benefit of our panelists, our second panel, we are continuing meeting number 26 of the House of Commons Standing Committee on Health. We are operating pursuant to the order of reference of May 26, 2020. The committee is resuming its briefing on the Canadian response to the COVID-19 pandemic. So I'd like to make a few comments for the benefit of our new witnesses. As you are speaking, if you plan to alternate from one language to the other, you will need to also switch the interpretation channel so that it aligns with the language you are speaking. You may want to allow for a short pause when switching languages. Before speaking, please wait until I recognize you by name or during questions by the member asking questions. When you are ready to speak, you can click on the microphone icon to activate your mic. A reminder that all comments should be addressed through the chair. Interpretation in this video conference will work very much like in a regular committee meeting. You have the choice at the bottom of your screen of either Floor, English, or French. As you are speaking, if you plan to alternate from one language to the other, I think I already did that. When you're not speaking, your mic should be on mute. I would like now to welcome you individually. For the Canadian Dental Association, we have Dr. Jim Armstrong, President, Dr. Aaron Burry, Associate Director, Professional Affairs. For Doctors Without Borders, we have Dr. Jason Nickerson, Humanitarian Affairs Advisor. And from the Ottawa Hospital, we have Dr. Dave Nilopovitz, Head of the Department of Critical Care. So each group will have 10 minutes to make a statement. So we will start with the Canadian Dental Association. Dr. Armstrong or Burry, please go ahead. 10 minutes, please.
So thank you very much, Mr. Chair, and good afternoon to the members of the committee. It's my pleasure to present to you today on behalf of the Canadian Dental Association. I've been serving as president of the CDA since April, but previously I've served on the board for the past 6 years, and I've volunteered in dental associations across the country for 3 decades. I'm also the managing doctor for Dental Cooperative with 10 practices and 150 team members throughout Vancouver. As well, I'm an adjunct professor for the Sauder School of Business at the University of British Columbia. I'm an MBA dentist. I'm pleased to be joined today by Dr. Aaron Burry, who's CDA's Associate Director of Professional Affairs. Dr. Burry is a public health dentist with more than 30 years experience of navigating issues with both practice and public policy. He's also an MBA dentist. In addition to the work that he has done to lead the CDA's work in understanding and addressing the challenges of COVID-19 for our profession, Dr. Burry has been serving emergency patients in a public health clinic throughout the past few months and can share with you that unique perspective. We come today with 3 essential recommendations to share. First, that greater consideration be given to dentistry as vital frontline healthcare workers when considering access to PPE. Second, that the federal government create a specific oral health envelope of $3 billion as part of the Canada Health Transfer. Third, that basic oral health standards be part of any future review of the state of health in long-term care facilities. I'll come back to each of these recommendations throughout my remarks. But first, I'd like to walk you through the challenges that dentistry has faced as a result of the pandemic, as well as those that are emerging. In March, by public health orders, dental clinics across Canada ceased providing oral health treatments, with the exception of very restricted emergency care, which was designed to keep away patients from the emergency operations of hospitals. Now, dental clinics are cautiously beginning a staged return to practice in accordance with the guidance set out by their provincial dental regulators, public health authorities, and workplace safety regulators. This guidance has varied from one province to the next and has resulted in great confusion amongst dentists and patients. Also within provinces, there is unfortunately conflict in regulations sometimes between those regulators that require different protocols or procedures be used when providing the same type of treatment. This also leads to significant confusion and angst for dentists as they attempt to establish the new normal. What dentists are finding as they return to practice is a physically demanding and mentally exhaustive experience. Dental offices are essentially mini outpatient hospitals, And like any hospital offering outpatient care, we follow strict infection control procedures and practices. That's not new. However, the new guidance and regulations stemming from COVID-19 have made performing outpatient procedures more difficult, physically draining, and time-consuming. Dentists must do considerable additional preparation before seeing each patient, and our early experience in getting back suggests they treat 50 to 67% fewer patients per day. Communication with those patients is also much more difficult. And it's not simply a single aspect of the new approach that is problematic, but rather it is a cascading effect of changes to how every aspect of care is changed. From the pre-work before coming to the office, to the parking lot, which has now become our reception area.
Pardon me, doctor, could you hold the mic a little closer?
Sure.
Yeah, please carry on.
From the pre-work before coming to the office, to the parking lot, which has now become our reception areas, to the clinical areas where far greater separation between patients must be maintained. Also, ensuring that the expanded range of PPEs is properly worn, removed, and decontaminated has significantly changed the way we work. The workflow of the office has changed to where there is absolutely no flow at all. Now, some of this may resolve over time, but these challenges are putting a strain on dental practices and our ability to provide care. Of course, these challenges presuppose that one has access to the PPE to perform the necessary procedures. From the onset of the current crisis, dentistry identified the impending shortages of PPE as a critical issue for us. We reached out through the Public Health Agency of Canada and through the Office of the Chief Dental Officer of Canada to reflect that the critical shortage would hamper the ability of dental offices to provide emergency care. Now, we recognize the multidimensional challenges that led to the shortages of PPE. The current and unprecedented demands for these materials has been exacerbated by the problems in supply chains, especially in China. In fact, early in the pandemic, when all hospitals were critically short of PPE, many dentists across the country stripped their offices of their own supplies to donate to the frontline causes in their communities. But with dental offices reopening, it's important that we emphasize that dentists are frontline providers as well. While we had initially hoped that access to PPE through our traditional sources would improve as supply chains reopened, our new supply chains emerged, that has not yet happened. Some materials, such as latex gloves, have become much more difficult to acquire. Individual dental offices are also attempting to acquire the same kinds of PPE as large government entities, most notably N95 respirators, which are essential and for many cases mandatory for dental care today. These government organizations, include the Government of Canada, can leverage their might to acquire mass quantities or impose guidelines on suppliers that have them prioritizing supply delivery to those entities actively on the front lines of the COVID-19 fight. The result is a supply of PPE which remains very scarce, if not impossible to access, and at rising prices due to demand. For dentists in Canada right now, to serve our patients appropriately, we currently need 1 million pieces of PPE per day. And this need will increase to 4 million pieces if we can reach full capacity again. As governments and healthcare providers work together to find long-term solutions to sourcing and maintaining a consistent and dependable supply of PPE in Canada, dentistry needs to be at the table. And this echoes the concerns that we have stated for several years about the state of public funding for oral healthcare services in Canada. Most Canadians are able to access care through employer-sponsored benefit plans. Unfortunately, our public programs have been chronically underfunded across the country. Just 6% of our dental care is provided to Canadians through public programs. However, growth in the usage of publicly funded oral healthcare programs is particularly acute amongst low-income seniors, children, and individuals with physical and developmental challenges. The new normal will mean even greater challenges in providing care for these individuals if care can be provided at all. Over the past decade, the erosion of provincial territorial funding of these programs has created a circumstance where the needs of these vulnerable groups are no longer being adequately met. With the profound economic challenges from COVID-19 to come, many Canadians will lose access to their employer-sponsored benefits. This will place an even greater strain on these public programs. The federal government has a clear role to play in helping to ensure that these provincial and territorial programs can appropriately address the challenges to come. Specifically, we recommend that the federal government create a specific oral health envelope of $3 billion as part of the Canada Health Transfer. At a time when there will be many demands on public health care dollars in Canada, we simply can't afford to allow these programs to wait at the back of the line and hope that funds will flow through. Finally, as we consider the challenges ahead, we clearly recognize the crisis within long-term care facilities across the country. Several years ago, CDA had asked the Department of Veteran Affairs to include basic standards of oral health care for veterans in long-term care facilities. It was our hope that these standards could have been instituted, benefiting not only the veterans in the facilities, but all of those who resided in the facilities. Unfortunately, we were informed that Veterans Affairs did not have contracts with these facilities, but only contribution agreements. That left it to the provinces to ensure that appropriate care was provided. Our suggested standards are not onerous and are at the very least the minimum we believe should be provided to any senior in care. They are an oral health assessment on intake, a daily oral health plan, a yearly visit with a dentist, and a location within the facility where dentistry can be performed. And we recognize that there will be large and far-reaching discussions on how to best care for seniors in these facilities. And these oral health care standards might seem minor in the current context of COVID-19. But these small steps can help to contribute to the development of a culture of care, oversight, and responsibility that will be critical to setting things right for Canada's seniors. So on behalf of Dr. Burey and I, thank you very much for your attention, and we'd be happy to take any questions.
Thank you, Doctor. We go now to Doctors Without Borders, Dr. Nickerson. Please go ahead, 10 minutes, please.
Great. Thank you, Mr. Chair, and thank you to the members of the committee for the opportunity to speak with you about the COVID-19 pandemic and the actions that Canada can take to ensure that people everywhere are able to access the medical care that they need. By way of introduction, I am the Humanitarian Affairs Advisor for Doctors Without Borders, or Médecins Sans Frontières, MSF, based here in Ottawa. I'm also a respiratory therapist with clinical and public health experience across Canada and internationally, and have a PhD in population health. I've worked as a clinical scientist in Canadian hospitals and universities. MSF is an international medical humanitarian organization that provides impartial medical assistance to people in more than 70 countries. We deliver essential health services in some of the world's most complex environments to people affected by conflict, epidemics, natural disasters, and other emergencies. But today we are facing an unprecedented crisis, created both directly and indirectly by the COVID-19 pandemic, which has reached all of the countries where MSF works. In these places, the pandemic amplifies and deepens existing inequalities. MSF sees this on the front line every day. We are witnessing COVID-19 cases that are occurring alongside existing emergencies and creating a dangerous set of public health risks. In the refugee camps of Cox's Bazar, Bangladesh, nearly 1 million Rohingya refugees live in overcrowded, unsanitary conditions that are perfect for spreading COVID-19. In Haiti, a country where I have worked many times, our teams have opened a COVID-19 treatment center that within days became full and had to double its bed capacity. We've had several patients who have died on arrival and many more who arrived critically ill. There are only 2 laboratories in the country capable of conducting COVID-19 testing, and the health system is ill prepared for what may come. Amidst all of this, we are all coming to grips with an uncomfortable reality, which is that our only way out of this pandemic is likely through a vaccine that does not yet exist and which needs to be globally accessible to virtually every person on the planet quickly. 2 months ago, I wrote an article that warned that given the way the global medical research and development system operates today, we face a real risk that despite the public, that is taxpayers, investing in the science to develop COVID-19 vaccines and medicines, they may become unaffordable, inaccessible, privately held commodities rather than globally accessible public goods. Public investment in COVID-19 science is essential, but we need to rethink our policy approaches to maximize the benefits of this investment. Today, the pipeline of COVID-19 vaccine candidates is robust, with more than 100 candidates in preclinical development and 10 in human trials on 8 different vaccine platforms. Many vaccine candidates are benefiting from billions of dollars of public and philanthropic funding, including more than $850 million of Canadian funding for COVID-19 diagnostics, treatments, and vaccine R&D. But the global research and development system is not designed to prioritize affordable access, especially outside of wealthy countries. Access to life-saving medicines is inequitable. This is not a problem that's unique to COVID-19. Rather, it is a failure of the global medical innovation system to prioritize diseases with the greatest public health threat. COVID-19 is only the latest example and has made it clear that we need to rethink the way that we do drug and vaccine development to prioritize patients and public health over profits. Today, here's how the system often works. Preclinical discovery and work, which is what much of Canada's domestic funding is currently supporting, is done by university researchers or other publicly funded institutions. This committee has heard from some of them who are working on COVID-19. From there, promising drugs and vaccine candidates, often very early stage, are sold or licensed to the private sector for subsequent development, in most cases with no strings attached, no requirement that the final products be made affordable or priced fairly, and no requirement to develop them quickly or to share the data and technologies with anyone who needs them. They become private market commodities and we lose control over them, save for perhaps some small royalty payments. 2 years ago, I sat before this committee during its study on federally funded health research and described how, as a result of this system, MSF teams have struggled every day for nearly 50 years to access medicines, vaccines, and diagnostic tests for our patients. When they exist, they are too often inaccessible, either because of their exorbitant prices, which bear no relationship to the cost of developing or producing them, or because companies simply choose to not register them in the countries where we work because our patients do not represent a lucrative enough market. For decades, we have witnessed millions of people denied treatment for diseases such as HIV, tuberculosis, and hepatitis C as a result of unaffordable patented medicines. The system cannot continue as it is, not for COVID-19, nor for any other health condition. The committee's 2018 report made 9 important recommendations that should be guiding the Canadian innovation response to the COVID-19 pandemic. To my knowledge, unfortunately, none of the committee's recommendations that could have helped ensure fair global access to health technologies being developed with Canadian public funding have been adopted yet. The report included a recommendation that Canada implement common sense safeguards to ensure that licensing agreements include specific requirements to ensure global affordable access. These provisions have already been voluntarily implemented by some Canadian universities, and in their most basic sense would require recipients of public funds to have enforceable safeguards in place to ensure that any medicines, vaccines, or other health technologies developed with Canadian public funding be made available at fair prices in every country where they are needed, including in Canada. Essentially, it's a requirement that an investment of public funding will deliver publicly accessible and affordable health technologies. In other words, a fair return on investment for the Canadian and global public. I'm sure we can all agree that it would be unacceptable if a vaccine to prevent COVID-19 or a medicine to treat it was developed with Canadian public funding and yet not made available or accessible for billions of people living in low and middle income countries, or to Canadians for that matter. And yet, without the right policies in place to share these technologies and the rights to them, access to them is at risk. Now is the time to put patient lives ahead of private profits. Here's what Canada needs to do. First, recognize that the pandemic is global and that if we allow the race to develop and access COVID-19 vaccines, treatments, and diagnostic tests to descend into nationalism or for access to be determined by who can pay the highest price, we all lose. Not only would allowing wealthy countries to have access to essential medicines while poorer countries go without be unconscionable, it would also be ineffective. Until all countries and all people have access to new COVID-19 vaccines or medicines, we cannot end this pandemic. Second, operationalize the Prime Minister's commitments to ensure that vaccines and other public health tools are produced at a scale and a cost that is accessible to all countries. Despite the current rhetoric that we have seen globally around making COVID-19 vaccines and therapeutics, quote, global public goods, or, quote, the people's vaccine, public funders, including in Canada, have so far failed to impose enforceable public interest conditions on recipients of public funds. Ensuring a public return on public investment should be a guiding principle behind all Canadian funding for the development of new medicines, particularly during a pandemic. Canada should also demand transparency in all stages of the R&D that it funds, including the registration and public reporting and sharing of clinical trial data, R&D costs, manufacturing costs, and product prices. If the public is investing to develop these life-saving technologies, we should be able to keep control and transparency over what we have paid to help generate. Third, endorse open science and reject monopolies on COVID-19 technologies by sharing the technologies, data, and knowledge with a global platform. Researchers have worked collaboratively and openly to share an immense amount of data, knowledge, and materials to understand this virus and its weaknesses. This has consequently shortened the time frame from years to mere months to develop candidate vaccines and medicines. This openness has been an exception to the rule. And given the way the global research and development system works outside of a pandemic, there's a real risk this innovation process will instead become closed and proprietary. Unless significant safeguards are put into place to mandate access, affordability, transparency, and knowledge sharing, we will be allowing our discoveries to be privatized and sold back to us and to people around the world at prices that we don't control because, as a rule, we don't even try to negotiate these rights. To put it in industry terms, not doing these things is simply a bad business decision. No privately run company in the world would sell a technology that they invested in and know they will need access to in the future without negotiating fair and reasonable access rights for themselves. Neither should we. We are not alone in calling for these actions. An ongoing petition on MSF's website calling for Canada to impose these common sense safeguards on the health technologies we are paying to develop has garnered more than 28,000 signatures in just over 3 weeks. Canadians want action to ensure people around the world are able to access the vaccines and medicines that we are investing in developing. We need you to take responsibility for what is coming next. We are increasingly worried about countries like Bangladesh and Haiti and others, where the cumulative impact of COVID-19 on top of existing crises is producing critical humanitarian needs. Canada needs to continue its global solidarity and support for international humanitarian assistance. But Canada also can and should demand a better deal that ensures global patient access and affordability in exchange for the use of the COVID-19 technologies that are developed with Canadian public funds. This pandemic is teaching Canadians many things. One of them ought to be that we need to rethink the way that we do drug and vaccine development to put patients over profits. Thank you very much for having me today. I want to emphasize that if members of the committee have any additional questions or want clarification, they're welcome to contact me directly. Thank you.
Thank you, Doctor. We now go to Dr. Nilopovitz for the Ottawa Hospital. Dr. Nilopovitz, please go ahead. 10 minutes, please.
Thank you. Good afternoon. Thank you, Mr. Chair and the members of the committee. I am Dr. David Nilopovitz. I am an intensive care unit physician who's actually cared for COVID-19 patients in our intensive care unit during this pandemic. I have seen patients make miraculous recoveries from this virus. I've also cared for patients who have died from this disease, including a tragic story of a husband and wife who had been married for over 50 years, who both succumbed to this virus. I'm also the lead for critical care for Ontario East, as well as I've been the head of critical care for the Ottawa Hospital for almost 10 years. As such, I was part of the groups responsible for organizing how intensive care units prepared for caring for patients during this pandemic. As such, I hope to bring the perspective of both ICU healthcare professionals and also that of critical care administrators who have been challenged by this pandemic. The COVID-19 pandemic certainly brought out the best in many healthcare professionals. It also brought to light some weaknesses and failings of our Canadian healthcare system. An obvious failing was how our long-term care facilities operate, which I suspect will be a major focus of this committee. However, I would like to highlight another weakness, which is that of the capacity of intensive care units, and particularly how they operate and how patients enter them. Had Canada experienced a response to COVID-19 in a manner similar to New York City or Italy, the focus, I believe, of the reviews would likely have been on intensive care units and their shortcomings. Early concerns to COVID-19, as many will recall, was would we have enough mechanical ventilators for critical care patients? That, however, is only one important aspect of ICU care. If I don't have the space or monitors, or most importantly, the staff to care for patients, more ventilators are essentially useless. My team at our hospital was able to increase our level 3 ICU capacity, level 3 being the highest possible level of critical care, from our existing 57 beds to over 200 beds, a well over 300% increase. We were not alone, as many sites across Canada were able to increase their capacity by more than doubling their existing level 3 ICUs. This, however, would not have been enough if we were New York City or Italy. So how could we improve the situation and done better? There are 3 strategies that I'd like this committee to consider. First and foremost, there are no national standards or expectations for intensive care units in Canada. How ICUs are structured, how they operate, how they are staffed, and even how they are equipped have no national standards or real expectations. Some ICUs that claim to be a level 3 ICU only had enough ventilators for 20% of their beds, for example. That, quite frankly, is unacceptable. Many sites lacked formally trained ICU doctors and critical care nurses, in spite of funding being available to train nurses, and more importantly, that there are trained doctors who are out of work. This cannot continue. I would hope that our federal government will address this forthright. Second, if we had telemedicine capacity for critical care, we could certainly improve the ability of all hospitals to provide a higher level of care to all patients in Canada. I think we all know that Canada is a vast country, so the ability to provide care in all locations is challenging at best. If, however, we had a real telemedicine capacity, larger facilities like my own could help more remote locations, be they in the north or other various isolated facilities, provide better care to their ICU patients, their citizens, our Canadians, who most certainly deserve such a high level of care. A high level of care could have been provided in these communities, transfers of their sick patients improved or even avoided. As I'm sure you'll appreciate, sometimes, unfortunately, there's nothing that we can do for certain patients. By avoiding a transfer, however, these patients would be able to pass away in their own community, surrounded by their family and their loved ones, which is something greatly preferable than passing away alone in a facility that is remote from their home. A comprehensive solution from our federal government to improve telemedicine capacity in Canada would be crucial to improve this situation. It is with that I have a final third issue that would assist the capacity of intensive care units in Canada, as well as improve the care that is provided in intensive care units. All Canadians have a right to health care. For this, there is no dispute in my mind. The difficult and contentious issue, however, is what care do they have a right to insist upon? ICUs in New York City and Italy had to ration critical care. That is horrible and not right. However, some families insisting that their ICUs revive their loved ones, to subject them to therapies, including machines and medications, when there's no reasonable chance of recovery, is equally not correct. It is not appropriate and greatly limits the abilities of health professionals to care for other patients and puts an undue strain on our critical care resources. It is only a change initiated by our federal government that can address this issue. I would respectfully ask our government and this committee to please address this issue, even though it is unsavory, but it is sorely needed. Thank you again for giving me this opportunity to express the 3 ways the federal government could improve and increase critical care capacity in Canada, including improving ICU care by creating national standards, improving telemedicine capacity for critical care, and addressing the difficult issue of what care is or is not appropriate. I would be happy to answer or address any of these questions or other concerns and can also be reached directly. Thank you.
Thank you, Doctor. We'll now start our questioning. We will do 2 rounds of questions. We will start the first round with Ms. Jansen. Ms. Jansen, please go ahead. 6 minutes.
Yes, thank you very much for these presentations. And I'd like to start with Dr. Nickerson. The Canadian, a company called CanSino, who is working jointly with the Chinese Communist regime to develop a vaccine for COVID-19. And when the outbreak first appeared, the Chinese government silenced doctors and scientists and initially quashed information about the virus. And I know I wouldn't want to take a vaccine produced by a country with such a questionable track record. If we want to get Canadians vaccinated, should we be working with a communist regime that's shown so little transparency? Like, do you think Canadians would trust a vaccine that they produce?
Thanks very much for the question. So I don't know the particular details of the CanSino vaccine deal. I know that there were results that were published of a phase 1 trial, I believe in the Lancet, roughly 2 weeks ago. I mean, I think that the systemic global issue that you're pointing to is the fact that we need more transparency and open reporting of data for all medical innovations. And that's not a comment about this particular vaccine. It's a comment on the broader global research and development architecture and system. We need to ensure that there is a responsibility to transparently report and I would say share clinical trials data.
Would you be concerned though about particularly the non-transparency working with? I mean, we're putting I don't know how many millions of dollars into this study, so would you be concerned?
Well, as I say, I mean, I don't know the particularities of this vaccine. We're trying to keep track of more than 100 vaccine candidates around the world that are being evaluated. As I say, I mean, I think that what you're pointing at is the fact that data need to be openly accessible and available, regardless of who is producing it, so that the international community of experts who know about these things can independently evaluate it and assess the scientific merits of any medical product that's being evaluated.
Yeah, no, fantastic. Thank you. I understand that this particular vaccine they're using an HEK 293 cell line that they developed in '73 from an aborted embryo, and many Canadians will have an ethical issue with this. So I'm just wondering, what are your thoughts? Do you believe that it's wise to move forward with a cell line if we can't really reasonably expect full Canadian participation in a vaccination program like that?
So getting into cell lines is I'm the wrong PhD to be commenting on cell lines and vaccine vectors. I'm a population health specialist, so I'm sorry, I really can't offer an answer to that question.
Okay, and then I understand that the National Research Council has signed a contract with CanSino, and we're trying to figure out, like, if you sign something like this, can we ensure that this vaccine would actually be produced and distributed in Canada? It sounds to me from your presentation we can't, and I know we reached out last week and we couldn't get an answer from them, so I'm wondering if you have any thoughts on that. This makes me nervous.
Yeah, I mean, the global vaccine manufacturing landscape, I think, is coming into full view at the moment. And, you know, as with all of these things, the devil is always in the details. And I don't know the particularities of what's in the licensing agreement or the collaboration agreement. You know, certainly I know that there's near global consensus that there is no one manufacturer who is going to be in a position to mass manufacture doses of this vaccine, so or of any vaccine. So I think that the key point here is that, you know, the only way of ensuring sufficient quantities of vaccine or indeed of therapeutics for COVID-19 is going to be through a disseminated strategy of having multiple manufacturers in multiple countries producing quantities of these vaccines and medicines. We're going to have to collaborate in order to have fair and equitable distribution and allocation of all of these medical tools. There's really no logistical alternative to this.
Right.
We're everybody in the world who is working on this right now is struggling with this reality.
Yeah, they all need it. So, I mean, I know we're putting 1.1 billion, I think, into research funding that the Prime Minister has promised, and if there's no obligation for the companies receiving these Canadian funds to actually ensure we have access to the treatment or the vaccine, we're not really getting much bang for our buck. So that's a real concern. It seems like there's no upside for Canadians. So if we're putting all this R&D money and no guarantee, how are we going to ensure that we actually get access to this?
Well, I think there's a few things to remember here as well, is that, we don't know which vaccine candidate or therapeutic is going to be effective, right? We are only a matter of months into the clinical trials and the development of these things. And the development process is rushing ahead very quickly. And quite frankly, I think we have some of the best scientific minds in the world who are working on this. But as I mentioned in my presentation, the global medical research and development system is not designed around principles of global access and equitable distribution. And so, we need a different way of developing these.
Do you have a suggestion for another way?
Well, I mean, there are proposals that are on the table. There are global international intellectual property pooling mechanisms that are being proposed. That's effectively the idea that any intellectual property that is being, generated would be put into a pool that allows for multiple manufacturers to be able to produce it. Countries can use it, and so on. I mean, this is effectively a pooling of resources. But during the previous study that I participated in a committee, I mean, the answer was around principle-driven open science. I mean, we should have scientists who are working collaboratively, who are sharing data, sharing knowledge, building off of each other's technologies, and having this knowledge and know-how being fairly disseminated and distributed to anyone who can benefit from it and who can use it.
Thank you, Ms. Jansen. We go now to Mr. Fisher. Mr. Fisher, go ahead. You have 6 minutes.
Thank you very much, Mr. Chair, and thank you to all our witnesses for being here today. I'm going to stick with Dr. Nickerson as well, and I'll stick with vaccine development just for a moment, whereas Dalhousie is, I believe, having Canada's first clinical trials for a potential vaccine. Now, I was very taken by your ensuring equitable access to a vaccine, and I'm wondering if you could tell me if there are any good precedents or good practices from other jurisdictions that Canada can use as a model for what you're talking about, your ensuring equitable access. And I also appreciate the line you used, common sense safeguards.
Thank you. Yeah, I mean, certainly there are a number of alternative models of research and development that are underway around the world. I mean, there are organizations active in Canada. During the previous study that I'm probably going to keep coming back to, because there were some very good comments that were made. The Structural Genomics Consortium presented, and they're an open science outfit that is doing drug development in a different way. MSF is one of the founders of an organization called the Drugs for Neglected Diseases Initiative, which is effectively a not-for-profit pharmaceutical research and development organization that's developed, I believe, 7 different either new formulations of existing medicines, so pediatric HIV or anti-malarial combination therapies, or entirely new medicines. So one example being a drug called fexinidazole, which is a treatment for human African trypanosomiasis, or sleeping sickness. And it's an organization that's guided by a core set of principles. They work with researchers, they work with the pharmaceutical industry, with private sector. But I think that the key thing behind the work that they do, and indeed the work that the Canadian government should be doing at a federal level to create standards, is that the work is guided by a set of principles, and that's effectively that there's a need to ensure that the final products, whether it's drugs or vaccines, are affordable and accessible in an equitable manner to patients who need them. And there is a desire to develop medical tools that are being treated effectively as global public goods. And so you do that by, negotiating fair access provisions, about, having enforceable clauses in licensing agreements and contracts and so on, that sort of stipulate what is expected of any recipient downstream of the intellectual property or the data, the know-how, the substance of what's at the core of either drugs or vaccines, and clearly stipulating, how it's going to be priced, how it's going to be registered in endemic countries, how you're going to work with manufacturers to ensure global production and equitable allocation and so on. I mean, there are actually many examples of how licenses, of how different drugs and vaccines and so on can be developed in a different way. There's examples from the Medicines Patent Pool, from our organization, from, as I say, DNDi. And I think that the intent is not to replace the good work that's being done already in Canada. It's to recognize that we do live in a world where medicines are becoming increasingly unaffordable and expensive, and including common sense safeguards. Like if we, the public, is paying to develop or discover it, the strings attached to it need to be fair pricing clauses and an assurance that it's going to be made available to all patients everywhere who need access to it.
Sticking with equity and sticking with Dr. Nickerson, Patty Hajdu has said a pandemic anywhere can quickly become a pandemic everywhere. So given that mantra, can you tell the committee why you feel it's important that we work to ensure that every country has resources to be able to respond to COVID-19?
Well, as I say, I mean, I work for an organization that's operational in some of the most complex public health emergencies in the world, in more than 70 countries. I mean, I've worked in many different places that have very weak health infrastructure, and for which the ability to provide the kind of care that Dr. Neela Povitz was describing, almost certainly does not exist, or exists in very limited capacities. So in those kinds of places, a vaccine or a treatment that may prevent people with mild disease from progressing to a more severe form of the disease, I mean, this is absolutely essential for potentially averting a public health catastrophe being overlapped on an existing emergency. And I think it's quite frankly as simple as that. We need these public health tools to be made available to everyone, everywhere, because quite frankly, it's ethically and morally the right thing to do. But also just pragmatically, this is an infectious disease that's communicable. We are in a global pandemic, and we've seen how quickly it can spread from one place to another.
Canada has done a pretty great job. And as borders get ready to reopen, what are your biggest concerns about places that have yet to do a great job, that have yet to flatten that curve in their countries?
Well, I mean, we're still trying to assess the impact of the global pandemic, on effectively a day-to-day basis. I mean, there are cases, as I mentioned, now in virtually every country where MSF works. I would say, interestingly, a lot of the countries where we work have public health professionals who are experienced in responding to disease epidemics and in working in different types of emergencies. So there is, in a sense, some capacity that exists on the ground that's actually quite experienced in doing things like contact tracing and so on. So we are very much still assessing and responding to needs as we see them. But as I mentioned, in places like Haiti, we put out a statement or a press release last week, describing the realities that we're seeing on the ground, which is that as moderate to severe cases start to occur, the potential for health systems to be overwhelmed or struggling to cope is patently evident.
Thank you, Mr. Fisher. We go now to Monsieur Thériault. Monsieur Thériault, allez-y.
Over to you, Mr. Thériault. Go ahead. Thank you, Chair. I will let Mr. Nickerson take a breath. But back to him now. Doctors Without Borders has a good deal of experience out in the field internationally in matters of pandemics. Doctors Without Borders has always believed in reducing risk and you considered closing borders or schools or even quarantine measures, saying that even if it didn't completely stop the pandemic, it would slow down its spread. And the World Health Organization had contradictory advice in this regard. On the 14th of March, they said, no, quarantine, border closures, forget it. 3 days later, the directors, at least at the European branch level, said that yes, it would help slow the spread. And Monday of this week, Marie Arkarkov, the person in charge of the technical management of the pandemic at the World Health Organization, said that the transmission of the virus by asymptomatic people was rather rare, and then the community of specialists reacted, and someone explained that 30 to 40% of the new cases were likely caused by asymptomatic carriers, and pretty much half of certain schools were already being affected, where most people indeed had the illness but were not showing any symptoms. So what do you think of the odd contradictions that came out of the World Health Organizations?
So, we are a medical care organization that employs physicians, nurses, public health specialists, people who are incredibly adept at responding to public health crises as they occur in the field, and we're no stranger to public health emergencies and outbreaks. I can tell you what our response has been in terms of just trying to evaluate and keep track of the emerging evidence. And I can say that it's we have teams of medical professionals with expertise in this area who are putting together guidelines and really just trying to keep track of the sort of evolving recommendations that are coming out. We are all learning as we go through this, and I think that there is great value in having coordinated voices and having clear guidance from public health officials around the world. So I think that my key message in all of this is simply to say that the evidence is emerging, it's evolving, and we're all doing our best trying to read articles in the Lancet and other medical journals as they emerge and appear.
Monsieur Thériault, go ahead.
Mr. Thériault, over to you. All right, I can see that you are offering us a very careful response, despite being your young age. But don't you think that the main organization at issue here, the World Health Organization, should be able to come forward with clear guidelines and be less contradictory and not hesitate as it did, and that would help us all move forward on a surer footing? So, in your opinion, the controversy around possible spreading of the illness by asymptomatic people, was this a bad thing or not?
A lot about public health messaging as we worked through this pandemic, and as I say, I mean, I to a degree I empathize with people who are in a position of having to communicate rapidly progressive, emerging evidence and an assessment of quite frankly imperfect evidence, because we're all learning effectively in the middle of a pandemic. And so I agree with the point that clear risk and communication and public health guidance is absolutely essential. But as I say, we're all learning in the middle of an unprecedented global public health emergency, and it's a challenge.
Thank you. I'm sorry, Mr. Thériault, you have 1 minute left.
Ah oui, ben alors,
Very well. So studies from the University of Montreal speak about the antibodies caused by infection with COVID-19, saying that 6 out of 10 people infected have developed antibodies within 2 weeks of first symptoms of the illness, and that this lasts 6 weeks, meaning that a vaccination strategy, when we have one, would mean that you'd need to be revaccinated very frequently. So are you concerned about the level of access that people will have to such vaccinations, given that it will be even more difficult to keep people immunized? And thinking of immunizing the entire population of the world.
I mean, yes, absolutely. And you know, one of the roles of international organizations is in fact to develop what are called target product profiles. I mean, what is the sort of ideal profile of a vaccine that would be deployed around the world? And I think that in designing sort of the ideal set of parameters that we would want a candidate vaccine to have, we and any other public health organization, I mean, it's absolutely essential that we take into consideration, and indeed that at the table are representatives of countries that are going to be particularly or potentially particularly disproportionately impacted by this. We know from other vaccines that you know, the way in which they're developed in terms of whether they're injectable or whether it's administered with a dropper, and you know, at what temperature it needs to be stored and how long it can be out of the fridge and how many doses are in a vial, and all of these things, you know, including those in the design and the development of vaccines at the early stage is absolutely essential for making sure that we have a vaccine that is well adapted for global use, so that it has, you know, all the maximum potential impact and efficacy. So what you're describing, I would say, is a good example of that.
Merci, Monsieur Thériault. We go now to.
Thank you, Mr. Thériault.
Davies, please go ahead. 6 minutes. Mr. Davies, you're muted.
Thank you, Mr. Chair. Thank you to the witnesses for being here. Dr. Nickerson, beginning with you, are there any international safeguards in place currently to ensure that COVID-19 treatment and vaccine supplies are distributed based on need rather than on national wealth or political clout?
Yeah, thanks for the question. So, I mean, as I mentioned in my statement, the short answer is that we are seeing these statements that are being made by a variety of different heads of state and other actors that seem to be committing to these sort of principles, let's say, of global public goods, of people's vaccines, of ensuring equitable access, and so on. And that is certainly a positive step. But as I mentioned, I mean, the global research and development system and the global sort of pharmaceutical system is not developed around these principles of equitable access. I mean, the system is designed in such a way to you know, effectively generate profits and to maximize those. So that we need enforceable language that's being included in funding commitments, that's being included in licensing agreements, and frankly imposed to achieve those objectives.
Well, let me move to a proposal for that. I understand the government of Costa Rica has proposed that the World Health Organization set up a global pooling mechanism of intellectual property rights, research, and data for all COVID-19 related technologies. And they say this would accelerate open innovation, support the scale up and production of necessary COVID-19 technologies and other things. Has the government of Canada made a public statement of support for that initiative?
To the best of my knowledge, no. I did check the WHO website earlier today, and I did not see Canada listed there. I may have missed it, but to my knowledge, no.
Thank you. Now, you talked about beyond just political commitments, the importance of safeguards. Has the Canadian federal government implemented any safeguards to ensure that COVID-19 vaccines, diagnostics, and therapeutics developed with public funding are affordable and accessible to the people and health systems that need them?
Again, to the best of my knowledge, the answer is no, and I've been following the work of the committee for the past while, and I know that this question was posed at one point, and I believe the answer was that there was no language to that effect in at least one of the funding agreements that was made. You know, as I mentioned earlier, I mean, this is not typically the way that the funding is rolled out in Canada. It's not there is no requirement on recipients of public funds to have some sort of global access licensing or fair access policy in place at the institutional level. You know, often the system works the way that I described it. We have researchers who receive public funding in university labs and other places. They do the discovery work, and then promising candidates are sold to the private sector with effectively no strings attached, and that should change.
Now, in March, you wrote an op-ed where, and I'll quote from it, you said, Canada may not even have to depend on commercial partners to bring medical innovation from the lab bench to the patient's bedside. The experience of the Ebola vaccines development shows that public sector researchers did much of the heavy lifting in the development and even manufacturing of early batches of the vaccine. We have experts in clinical trials in our hospitals, universities, and vaccine research groups who are more than capable of doing the necessary clinical trials to develop and deliver new health technologies quickly and affordably. In your view, would a public drug and vaccine manufacturer like Canada used to have with Connaught Labs help ensure affordability and the development of medications and vaccines that are developed obviously through public funding?
Yeah, so I mean, I've said this a few times now, but the pace at which the science is unfurling in the COVID-19 vaccine and therapeutics developments is absolutely unprecedented. And when I wrote that, you know, the CanSino collaboration agreement didn't exist yet. But you know, I think that point is emphasized by the fact that, as Mr. Fisher mentioned, you know, the clinical trials work is going to be done by researchers at Dalhousie University who have expertise in doing these kinds of clinical trials. I mean, there is expertise in at least doing some kinds of phase 1 through phase 3 clinical trials that exists in universities and other research institutes and in other places. I mean, there are models of innovation that do not have to rely solely on the sale of you know, early stage promising drug and vaccine candidates to the private sector. There are different ways of doing this.
Thank you. Mr. Chair, do I have time for one more question? Thank you. Maybe the Canadian Dental Association, thanks for being here. We know the work the CDA has done identifies about somewhere between 33 and 35% of Canadians have no dental coverage at all at any time. And now, as you pointed out, we know about 3 million Canadians have lost their employment as a result of COVID-19. And with that, any dental coverage that they may have had through their employer. Do you believe it's time to reevaluate Canada's method of delivering dental care so we can ensure that all Canadians get access to this essential oral health?
You like me or Dr. Bury, the public health expert, to answer it?
Whichever you prefer.
I'll go first. I do think it's time. You know, and that's why we made our proposal. And I think there's a lot of different ways we can look at it. As Dr. Nickerson said, you know, we're in the midst of trying to figure out how our systems are, you know, there's so much that we're learning about the shortcomings of the systems through this COVID crisis. You know, I think there's interesting aspects from the Affordable Care Act that was in the US. There's European models. And we've done a lot of research over the last 18 months on various types of models, various different types of models to care for those patients. But there's going to be more Canadians lose their oral health coverage, and they're going to need access. So we absolutely agree.
Thank you, Mr. Davies. We go now to, that brings round 1 to a close. We start round 2 with Dr. Kitchen. Dr. Kitchen, please go ahead. 5 minutes.
Thank you, Mr. Chair, and thank you all for your presentations. Dr. Armstrong, and I'm going to start with you, and just so you understand, I was the registrar for the chiropractic profession in Saskatchewan, and then I was the president of the organization. So I recognize that there's a difference between the association and the regulatory body, but I suspect during these times that you've been in close contact with the College of Dental Surgeons. So if you feel there's an answer that you can throw in there, I appreciate it as well. Now, according to the Federal Economic Response Plan on your CDA website, the financial assistance programs introduced by the government may not be applicable to certain dental practices, as each situation depends on the business structure of the individual practice. Have you experienced a lot of turmoil amongst the many practices?
Yeah, thanks for the question. Yeah, you know, there's about 18,000 practices in Canada, and we probably got 19,000 different ways we're organized. But what we have found is the federal government's been very, very good at being able to address and change some of these. So some of them, you know, the wage subsidies have been really, really important. We hope those continue. That would be nice if it continued past August. But I've got to say, you know, normally I don't love politicians, but I love all politicians right now, because I think by and large, we've gotten more things right in our response, our economic response to COVID. And certainly the federal government seems very flexible in looking at some of these things.
In your projections and in your deliberations, has the CDA relied at all on PHAC and on the data they provide for COVID-19?
I'm going to let Dr. Bury answer this one, because he's more knowledgeable on this. Aaron, could you answer this?
Yes, absolutely. And we do participate in a lot of different conference calls with PHAC around everything that's been going on with respect to COVID. We as an organization do a national wrap up virtually every week since this started, and are using data from PHAC and other organizations to sort of make sure that the dentists across the country understand what's happening and what has been going on in terms of this. For the biggest part for dentists is to understand what's going on in their communities, as well as what are the trends, and particularly as they look at reopening and reestablishing practices. Many of us have stayed open and provided emergency care throughout, but others are now starting to bring more services online and understanding what the course of this pandemic is, as well as any other information that PHAC could provide to us.
Thank you. Can you give me an idea of sort of, I mean, I realize there's lots of change. And first of all, I guess I'd like to thank the whole dental profession, because I know they stepped forward with PPE equipment at the outset of this, and a lot of them gave up their personal PPE, and your recommendations about getting priority access to it is important. How much discussion are you getting with PHAC on that issue in order for you to get access to that equipment such that we can provide oral care to Canadians?
So in terms of those conversations, I think what the federal government has done in terms of trying to clarify who is actually a legitimate seller and reseller of PPE in the country has been helpful. What is, I think, unfortunate is that our dental suppliers, those companies that have it, simply don't have the supplies to be able to give to dentists, and it seems to be it's sort of a national problem. That's what we hear, and I think it's a growing issue for dentists in terms of what they do have in terms of supplies will run out as we start to increase the amount of care that we need to provide, and really address things that have been put off for several months. So I think in that respect, I think it is a global frustration in terms of not being able to access and refill things as quickly as we would all like to see at this point.
Thank you. Appreciate that. Now, I realize, there's a lot of changes interprovincially, et cetera. In Saskatchewan, there are different issues that are attacked here. For example, here in Saskatchewan, the dentists seem to have the most strict adherence and regulations, whereas Ontario has changed in the last 3 days, has changed theirs from being strict to not. And we have some of the fewest cases here in Saskatchewan. So I'm just wondering, does the CDA feel that the jurisdictional approach to reopening is working for their sector, or should there be some kind of national standard or guidance that would have been more helpful?
I think across the country, everybody would benefit from a more standardized approach to and more national, perhaps, leadership around what the guidance should be at the provincial level. I think the variety of guidance that you have in every province and every level is challenging. At the same time, you also have to respect and understand that I think local decisions are based on local capacity. So we heard earlier about what is the capacity from a healthcare system to be able to respond. And so I think what you're seeing is medical officers in certain part of the countries are responding to the fact that they don't have the same level of medical support. They're worried about it. So therefore, they're asking the dental community to do more in those particular jurisdictions. But I think it does speak to what you have when we have a very large, diverse system in Canada, where people looking at the same information are coming up with different answers.
Thank you, Dr. Kitchen.
Thank you.
We go now to Dr. Jaczek. Dr. Jaczek, please go ahead, 5 minutes.
Well, thank you, Chair, and thank you to all our witnesses today for your presentations. And each of you has alluded to a stronger role for Canada in the areas that you each work in. So I'd like to ask my first question of Dr. Neela Povitz. You alluded to national standards for intensive care units. How would you see that those standards, given the fact that health is in essence a provincial jurisdiction, how do you see the development of those national standards?
Thank you for the question. It's always been the challenge of provincial versus federal, and I'm not naive to think it's a simple solution. However, a national standard is what most of our societies go by, and I think there's an easy opportunity for the federal government to work with the provincial counterparts and actually set expectations for what critical care units would have. So it would be led by the federal government, working with the various provincial counterparts along with our national society. And that could be set with, this is what we expect a level 3 ICU to provide, and the various other components. And I think provinces would welcome that, physicians would welcome that. So maybe I'm naive to think it is easy, but I think a national standard is what we would all look to. We have national standards in the operating room and various other locations. Why would we not in our intensive care units?
Thank you. Now, it appears the Ottawa Hospital was well prepared. You planned in advance, obviously experiences from before SARS and so on seems to have meant for the Ottawa Hospital to be very aware of pandemic planning. How are you preparing for a potential second wave? What is that looking like for the Ottawa Hospital?
Well, I can speak to the Ottawa Hospital, but also Ontario. And I think Ontario, as you pointed out with our experience with SARS, was perhaps better prepared than some of our counterparts in that we've been planning this for about 15 years. And so, and we've had practice runs, be it with H1N1. So what we're doing for the second wave that may or may not come is that we continue with our preparation and ensuring that there's adequate amount of PPE, the personal protective equipment for us. There's additional ventilators coming in almost weekly, and so we have that. I'm working with counterparts in other areas to say how can we work together with it. It's actually been a very positive experience seeing the cooperation between all the sites. And so I think that's something that Canadians should take some solace in knowing, so that we're working on that. We're revising our protocols and practices with it, and we're sharing. So along the lines of what's going internationally that was being advocated by Dr. Nickerson, we are certainly doing that in Ontario and working with that. We're also trying to develop ways for us to identify when perhaps a second wave is beginning. Looking for measures and signals such that we would be able to prepare quickly, but not impact other healthcare is what seems to happen in the first wave.
And how about the issue of burnout in frontline workers? Intensive care unit work is obviously extremely stressful for those working in those units. How have you been dealing with the mental health aspects that inevitably occur under such stress?
I think talking and sharing experiences. I'm actually been quite impressed with what some of our societies, as well as has been provided by at least my own government in Ontario to allow us mental health and mindfulness types of strategies. I'll be honest, it's not just critical care that's been stressed. I think we should recognize that other areas of our hospitals and healthcare professions have gone out and helped in environments that they're not familiar with. I know that a lot of the operating room staff, I'm also an anesthesiologist, they volunteered and given of their time and cared for patients in the long-term care facilities. I do worry the longer this goes on and how protracted it will be, including the restart. It certainly will be taxing our nurses, our respiratory therapists, our other specialists, and our physicians. And so I do think the assistance that has been provided for corporations has been helpful for physicians. The added pay for our health professionals was certainly welcome. And I do think a strategy long-term on the mental illness effects secondary to COVID, both on health professionals, but as well as on Canadians in general, should be a major consideration for our government.
Thank you, Dr. Jaksic. We'll go now to Ms. Jansen. Ms. Jansen, please go ahead, 5 minutes.
Yes, thank you, Dr. Nilopovitz. I was hoping I could ask you a few questions. I was wondering, what percentage of ICU beds did Ottawa use at the peak of the pandemic? I think you mentioned it.
Well, we're a 57-bed with the two campuses. And unfortunately, believe it or not, critical care wasn't stressed in most centers across Canada. So we were roughly about 80% use.
Okay.
We never had to go into our pandemic areas.
Okay. Now, we heard the Prime Minister right in the very beginning, he was talking about that our healthcare has plenty of surge capacity, our system. And I know that my first thought was, well, every Canadian knows there's no surge capacity in our system once you sat in emergency for a few hours. Do you feel that shutting down important medical services like cardiac surgeries and so forth constitutes actual surge capacity, or is it just more a rob Peter to pay Paul in a manner of speaking?
Well, I think but by the nature of your question, you know the answer in that there was, we were affecting other people's care. And I think that is the reality. It's one thing to take away emergency surgery, which really did not happen. Most of it was elective surgery that was impacted. There was some surge capacity that is inherent into our system. I think there are ways to improve it. But
what's your thoughts on that? Like field hospitals? I don't think we really utilize that at all, like keeping COVID away from other processes, perhaps with field hospitals. Has that been thought about at all?
Hospitals were explored, and I was part of groups that explored and discussed it. That's easier said than done. To suddenly open a bunch of surge hospitals. Like, we could open it, how do we staff it? How do we supply it with equipment and things as such? I think there's other more effective strategies. I think most Canadians are now aware that acute care hospitals have a lot of patients who would be better cared for in a long-term care facility, which is certainly, unfortunately, in short supply. And so that is a huge issue going forward. And now with changes in long-term care, it has stressed out acute care even more. So I think a comprehensive long-term care strategy is long overdue for all of Canada.
Right now, hearing all the needs that the healthcare system has following this pandemic, and I mean, today's panel is obvious, we have tremendous amount of needs. It seems almost too big of a problem to solve. And, you know, if every hospital needs to be updated, it feels like it's a little bit like trying to eat an elephant. So where do you even start? But is there a way to prioritize things? Like what would you say would be the most critical change that needs to be made to our infrastructure or whatever, that would be kind of low-hanging fruit? Is there something specific you could point to that would make a lot of difference that's you could get done right away without doing everything?
I think when it's a good question, and trying to boil the ocean is impossible for all of us. But I would really start with looking at long-term care. How do we get patients out of an acute care hospital that don't need to be there? I did allude to some of the challenges with end of life, and that certainly is a difficult topic to address. I do believe, however, it is important that we look at all aspects of end of life, not simply the MAID component that was addressed several years ago, but there's other aspects. But long-term care, I really do believe would go a long ways to help addressing some of the challenges that hospitals are experiencing. By far and away, our biggest issue and challenge is space. And if we were able to get what's roughly about 20% to 30% of all hospital beds emptied by patients who unfortunately have nowhere else to go, I think that would go a long way to help improving our healthcare system.
Right, and with a big wait list that have been created, are there any creative ways we can clear those up? So procedures we could deal with outside of the regular healthcare system could somehow perhaps take off the pressure, like private mobile radiology services or something like that. Is there a way to do this creatively? Because I mean, 7 years wait list for hip replacement sounds like a bad idea.
There's always creative ways to do it, and anytime there is a change in the system, there's actually an opportunity to make it better. And so I think we certainly have found a lot of efficiencies during COVID. Telemedicine has certainly helped a lot of aspects. All patients don't need to come to a hospital to be seen by a physician. So I think that is an opportunity. If we invest in our telemedicine, we'd be able to unload some of the burden that's going on with that. In terms of your ideas of private and outside of a traditional setting, you know, there is a downside to that, but there is an opportunity. And so certainly I think we should explore it, but recognizing our ultimate goal should be to ensure that care is provided to all Canadians in an equal fashion.
Yes.
Thank you, Ms. Jansen. We go now to Mr. Kellaway. Mr. Kellaway, go ahead, 5 minutes, please.
Thanks, Mr. Chair, and hello to my colleagues and to the witnesses today. I've said this before, I forget the number of meetings we've had. I should know that offhand, but it's been plenty during this COVID pandemic. And each of the witnesses provides so much information and knowledge to us and to myself and to the Canadian public. So I just want to thank you folks for this today. And I'm going to start my questioning with the Canadian Dental Association, and I'll stick to you have aha moments when you're asking questions, or more importantly, listening to the answers. And Dr. Armstrong, you talked about looking at dentistries as mini outpatients, and I found that an incredibly aha moment for me in terms of reframing perceptions versus realities in terms of healthcare. And you made a really interesting comment, and I want to kind of drill a little deep on it. You talked about, the $3 billion that could be invested or should be invested into the province from the feds. I'm interested in, and I think you've alluded a little bit to it, but I want to give you this opportunity to maybe do just a little deeper dive on what those specific elements, those areas of investment would be. And the second question, and I'll stay with the Canadian Dental Association, is dental services are beginning to resume across the country, as a lot of other healthcare services are as well. Can you tell us how dentistry is going to look in the next day, 24 hours, next couple of weeks, in terms of what it will look like now as opposed to pre-COVID? Thank you very much.
Okay, thank you for both questions. I'm going to start with the second one first because it's easier. I can't tell you how it's going to look because it's evolving daily. We had 3,000 new papers published, I think, last week on COVID. It's how long does this last? When do we get a vaccine? You know, how many, it's just, there's too many things to, how long are we going to have to change our processes? And I want to go back to Dr. Neil Lipovich's comment about telemedicine. You know, we're starting to use teledentistry. I think that's got, you know, great potential for being able to make care more equitable. And I think we've, you know, we certainly at the Canadian Dental Association, we want to make care more equitable, and we also want to drive costs out. We want to increase quality. And coming to your first question, the $3 billion, Canada underfunds compared to many countries the public health aspects of public support. And as you know, as one of your colleagues has pointed out, the Honorable Don Davies, you know, there's somewhere between 30-35% of Canadians lack funding or are having adequate funding. And what we're really concerned about is the number of Canadians who are going to lose it because this recession that has followed this pandemic may be very deep and long. So, you know, if the government, if there was a tranche of financing that was specific to oral health care, that would help, because what happens in dentistry right now is often our funding comes through social services, not actually through health. And we're the last dollar in, and we're the first dollar that gets clawed back. So we've got, you know, we've got really good private facilities, but we've also got really good hospital dental facilities that are just underfunded. And so I think if we could get that funding, you know, I think all of us have said that we would be open to any suggestions. We'd be open to looking at all ways in which to target this. But the issue is equitable access for all Canadians.
A bit of a running theme in today's discussions around equitable access, for sure. I'm really interested in learning more about teledentistry as well, because what we're seeing on the telemedicine side in Nova Scotia is that there has been obviously an increased uptake because of COVID, and people are getting a little bit more familiar with that concept and that practice. And I'd be interested in learning more about teledentistry. So thank you for that. My next question is for the witness from the Ottawa Hospital. I'm hoping you can walk through, I guess, what it's like for a person to be hospitalized with COVID at your hospital. And I'm interested in the treatment, but I'm also interested in the aftercare as well. I wonder if you can, for the panel here and for my colleagues and for Canadians, kind of walk through that for us, if you could.
It's a good question. I mean, the patients who present with it, there's several different types of presentations. So what one person's experience isn't necessarily the experience of everyone. Now, the patients I see, unfortunately, are the sickest of the sick. And so when they come in, many of them are struggling to breathe. There's also the fear and anxiety with just the syndrome itself and all the hype that's been around it. I think the caring that the nurses have certainly demonstrated is been fantastic. The one aspect that patients are experiencing that unfortunately makes them unique compared to any other disease and disorders is there's no friends or family that are around them. And I think that is a tragedy of this situation that we'll be talking about for years from now. And so we've done our best, at least in the Ottawa Hospital, to provide means of video to be able for them to see the people they really want to see. Like someone touching and holding them who's not their family is certainly better than no one, but I don't think it's the same as that. In answer to how they experience, they feel short of breath. They're struggling to breathe, some of them. And others, surprisingly enough, aren't as struggling, albeit that their oxygen levels in their blood that we measure are quite low. And so they experience that. The recovery, in part of your last question, certainly I know my rehab colleagues are doing their best to accommodate this. There's certainly a lot of unknowns that have been alluded to, whether or not people are actually infectious. And so they're doing their best to rehab these individuals. Some of them are staying on ventilators for almost a month. So you can imagine how much muscle and changes they've experienced.
Okay, thank you.
Absolutely. Thank you very much, folks.
So thank you, Mr. Kellery. We go now to Monsieur Désolé. Monsieur Désolé, allons-y, 2 minutes et demie, s'il vous plaît.
2 minutes and a half, Mr. Désolé. Yes, hello, and thank you, Chair. And hello, everyone. Thank you for being here. My question is for Dr. Lipovich. You were speaking of national standards, but also of the considerable collaboration that would require with the provinces. So what do you think of the health transfers, which are often requested, of course, by provinces?
Like, should they be increased? Should they be adjusted? Certainly, I think the idea of increasing funding, there's not going to be any physician who says we shouldn't fund more, although I think we need to fund smarter. I think that is something that we all share. And so in terms of the transfers, certainly we would like to see that increase, but I would also put back that I think we all need to be smarter with what we're doing. There's no bottomless pit of money that can come. And so there is an opportunity for us all to work together. I mean, I do work with my colleagues across the river in Gatineau. When this was coming about, you know, we offered our services to them, and I worked with my counterpart there. So there is collaboration between provinces. We can do this together, and funding can certainly follow where collaboration is leading the way.
OK. Vous souhaitez aussi que le gouvernement supporte.
You're also hoping that the government would support, and of your recommendations, I think it was the second one, that government support telemedicine in high care units. So could you tell me what that would be like in your type of service?
Thank you. That the opportunity is to build on what's actually being done around the world, that a center like mine would be able to get a video feed as well as information from the investigations and monitors, and be able to assist the teams that are there providing care, providing opinions, guiding treatments. And that way experts, even in various other centers, could be brought into to help improve the care that's going on in our more remote facilities. And so it's an opportunity both video, but also a better linkage to be able to see and know what's going on.
Merci, monsieur. We go now to Mr. Davies. Mr. Davies, please go ahead. 2 minutes and a half.
Thank you, Mr. Chair. Dr. Nickerson, in the previous Parliament, the Health Committee prepared and produced a report on open science, which recommended developing global access licensing requirements for medicines and vaccines developed with CIHR funding. To your knowledge, does CIHR have a global access policy for COVID-19 medicines and vaccines developed with public research funding, or does it require institutions receiving CIHR funds to have a global access policy?
I'm not a recipient of CIHR funding at the moment, but to the best of my knowledge, no, I'm not aware of there being such a requirement.
And I take it you would recommend that we do implement such a requirement?
Absolutely. I mean, this is one of the things that we recommended to the committee in the previous Parliament during this exact study, is that funding provided for the development of drugs, vaccines, diagnostic tests, other health technologies should be conditional on recipients of public funds having a policy in place that stipulates that if they are going to license it to someone else, that that be done in a way that includes provisions that ensure that it will be made affordable, accessible, priced fairly when it eventually comes to market. I think enacting these provisions early upstream gives a degree of control to be able to negotiate some of these provisions fairly effectively.
Thank you, Drs. Armstrong and Burry. I know you co-chaired the CDA's Return to Practice Task Force. And a couple of questions quickly. In your view, are all regions of the country in a position to begin safely reopening dental offices, at least for non-emergency services?
In terms of, I think the areas of the country, for example, on the East Coast where they haven't had any COVID infections for several weeks, I think it's, they're in a very good position to resume services and to be able to do that very safely. I think where we are still struggling are in places like Quebec and in Ontario where we have outbreaks and we're still monitoring that. And I think that's where going forward, I think some national standards and some sliding ability to look at when there's pandemic, what should happen in practice versus, we're trying to do this. And all guidance coming out has largely been interim. I think we have to remember that it's an interim guidance for a new experience. This is unprecedented. We haven't seen this before. So there is, I think, most of the practices are in a good position to be in opening, while there are questions like in the Northwest Territories where the medical officers there are very worried about the fragile nature of their health system and so on.
Thank you, Mr. Davies.
Thank you.
That brings round two to a close. I'd like to thank the panel for all of your time and your expertise and sharing with us your knowledge. I'd like to thank the members of the committee. And with that, we are adjourned.